So my name is Paul Innes. I'm a trustee of the PSPA board, and I'll be helping to maneuver us through the fantastic agenda and speakers that we've got today. So before we start, a couple of things I would like to do is just share with you the agenda. But before we actually do that, I'd just like to say thank you for giving up your time today to listen to some great speakers we've got lined up for you. And the other thing to say thank you for is for all the help and assistance you provide everybody that is living with and caring for PSP or CBD. The roles that you play make a huge difference to those people that are working their way through the conditions and the journey that they're on. So first up, thank you for doing that. So what I'm going to do is I'm just going to share with you the agenda. Hopefully you're all seeing the screen. Now, I'm seeing a couple of people in the chat saying that they don't have any audio. So that could be on your side. So it may be that the laptop or the device that you're using, the speakers are not switched on or they're set to low. That can often be the case. So hopefully that's fine. I've got Hazel in my sights at top left. Hazel, thank you for the wave. Hazel, you already confirmed that you can hear me. Is that still the case? Can you give me a thumbs up? All right, okay. So it's working from us to there. Okay, great. So, all right, so we've got some guidance there in the chat. Click audio, join audio. So hopefully that's got everybody up and running. We allowed a little bit of time for the acclimatization to the online event. So during that time, look, we've got 197 people now, so that's fantastic. I'm going to make a start. So for those that just joined, just to remind you, my name is Paul Innes. I'm a trustee of the charity, and I will take us through the agenda today and coordinate the wonderful speakers we've got. Now, hopefully you're all seeing the screen, and this is what we have in terms of the agenda for today. So at 10 past 10 in about 5 minutes, Boyd will walk through the management pathway, and so that's going to be a fantastic intro to the day, followed by Dr. Susan O'Connell. Who's going to talk through cognition in PSP and CBS. Dominic will then take us to that last session before we have lunch at 1 o'clock. We will probably take a break midway through. And then after lunch, we're going to have a conversation from Jade around physiotherapy. And then I'm going to share a presentation with you that I did to the research symposium a few weeks back. And then lastly, we're going to have Annalise, who's going to share a synthesis of everything that we heard at the research symposium, which was an absolute fabulous event, very inspiring to be there. So that's the plan for the day. So before we get going, I'd just like to share with you some housekeeping things. So everything that we're going to go through here is being recorded. So, and that's be made available for you and for others that couldn't make it today. So if you've got any colleagues that couldn't get here that would have loved to have come along, please do make them aware of the recording. Clearly what we'll be doing with the communications team at the charity is making that aware, be using our social channels and our other communication mechanisms. So the other thing is we may well be taking some photographs throughout the day. So if you don't want your face to be on any photos, because we may well use that for some socials and other bits and pieces, please just turn your camera off. There's a stop video icon top left of your screen that will just switch you off, and it will just leave your name. This is probably one of the most important things in terms of your housekeeping, which is to make sure that you've got your name visible. So I know sometimes some people come on and it comes on, it says iPad or Dad's iPad. always used to come on Dad's iPad. We knew it was Dad because we could see him. But with 196 plus people on this call, clearly there could be a lot of Dad's iPads, and we might not know you as Dad. So if you could change your name, that would be great. And the way you do that, if you look in the uh, um, if you look in the top right hand corner of your picture, there's three dots, and you click on that three dots, and at the very option right at the bottom it says rename. If you could put your full name in there, that's really, really helpful, because also when you put stuff into the chat, it comes up and uses that name, so we know who to call out to and stuff for anything like that when we get your questions a bit later. You should have all been muted as you came in. If you've not already muted, please do click the mute button top left. That'd be really, really great. Please stay logged in at the lunch break. You can just mute and turn your screen off and depart. That's absolutely fine. And we'll pick it up again after lunch and we'll be ready to go. So rather than coming in and out and stuff like that. If you could use the chat to ask any questions. Sorry, that was my Alexa just talking to me about the postman arriving. If we could use any the chat to do any questions, because we're not going to do any verbal stuff, as you can imagine, just the audio would be a bit tricky. If we don't get to answer every single question, which can be the case, we will ensure that every question gets a response, and we will email that to you all as well. If you do have to leave the meeting, or your laptop or iPad drops you out and you come back in again, just be patient. You'll go back in the waiting room. We're monitoring that, and we'll let you back in. Most importantly, please do share anything or any inspiration you've got or any great thoughts you have on social media. You can see that we've got, please use our handle, PSPA Association, at PSPA Association, and use the hashtag PSPA Study Day. And if you do have any technical issues, use the email there. We've got technical assistance online to help. Okay, so that is the plan for the day. That is so that's our plan. That's the housekeeping. We got a wonderful set of speakers to share some really great topics with you. I'm going to be quiet. I'm going to hand over to Boyd, and Boyd's going to kick us off. Boyd, are you ready?
I am. Thank you very much. I'll just share my screen.
Okay, I'll stop sharing,
yeah.
Boyd, so that you can share. So there we go.
So, there we go. That's the sound. So, Paul, you should be seeing the screen that says, that's just a first slide with management pathway. Is that right?
Yes, that's right. It's all there,
Excellent.
Boyd.
Excellent. Fantastic. So, hello, everybody. My name's Boyd Ghosh. I'm one of the trustees for the PSP Association, but I'm also a consultant neurologist in Southampton and Salisbury. And perhaps more importantly for today, I'm also the lead for the regional atypical Parkinsonian syndrome clinic that we run in Southampton. And that looks after people with progressive supranuclear palsy and corticobasal syndrome. We have a clinic coordinator and some other people who help us, and I'll go over our clinic in a little while as part of the presentation. So my disclosures are these. I'm also on the research committee for the PSPA, and I've helped some drug companies do some research looking at drugs for people with PSP and other diseases. So today, what I thought we'd do is we'd describe diseases that we look after and discuss the guidance that exists to try and help that. To help the people and their families, and describe our service as a possible service of what we might want to try and garner evidence for going forwards. So, what are PSP and CBS? So, they are progressive supranuclear palsy and corticobasal syndrome. Now, you may all be familiar or not with them, but I thought I'd go over a little bit about what they entail. So the prevalence for both is really about 4 to 6 per 100,000. And they're both levodopa resistant. So they look a bit like Parkinson's disease, but whereas Parkinson's disease would often respond quite well to dopamine tablets. PSP and CBS don't. And they both have a disease which progresses, unfortunately, to people passing away in an average of around 6 years, sometimes more, sometimes less. And perhaps most difficult for the patient and their family is that they rapidly become dependent, and their quality of life for them and their carers is really poor. So when they become dependent, they can't see very well because they can't move their eyes. They have poor mobility, um, uh, and they're really reliant on people around them to look after them. The pathology. So you'll have seen that the PSPA supports people with CBD, corticobasal degeneration. And why have I used CBS? Well, in the brain, we have lots of different pathologies. You might have Alzheimer's pathology or motor neuron disease pathology or PSP pathology or corticobasal degeneration pathology. But we don't have access to the brain when people are alive and come to clinic to see us. And so what we see from the outside is how they act or how they move. And so, for example, corticobasal syndrome is someone who has difficulty moving one arm or one leg in a certain way, and I'll go over that in a second. But that presentation, the way they present clinically, what they can do and what they can't do in a clinic room, might mean that they have Alzheimer's disease pathology in their brain, or it might mean that they have corticobasal degeneration pathology in their brain. And that's an important distinction to raise. Particularly as we think about treatments that work on different proteins, so Alzheimer's disease protein or PSP type protein. So what kind of problems do they have? So in corticobasal syndrome, they have poor mobility, so they often can't walk, and that progressively gets worse. They have poor speech and poor swallowing. They often have what we call asymmetric bradykinesia and dystonia. So that's what I mean by one arm or one leg might move more slowly. It might have increased tone, so more rigidity. And as part of that, they have what's called apraxia. So that's where there is power going to the arm and leg. There is sensation coming back from the arm and leg, but the motor program, which allows the person to move and carry out tasks that they think about, it doesn't work. So, and that's what we mean by apraxia. So often they have great difficulty miming gestures that you ask them. So can you saw some wood? They might not be able to use their arm appropriately to do that. And it's almost like their arm, for example, is untethered from them. It acts of their own volition. And so sometimes it can float up and it can do different things. And in that scenario, it's called an alien limb syndrome because it acts like an alien limb. It just does things on its own. People often will have sensation going to their arm, but they won't be able to integrate the sensations to try and work out what's going on. So for example, if you draw a number on their palm, they can feel you touching their palm, but they can't work out where you're touching it with sufficient precision to enable them to decode what the number is. And they have cognitive problems, and that might be part of the fact that some pathology might be Alzheimer's disease pathology, and so they might affect later on in the disease some parts of the brain that are affected in Alzheimer's and give them memory problems. So that's corticobasal syndrome. PSP, so progressive supranuclear palsy. This is a disease where people usually present with falls. So the first presenting feature will often be a fall. The second characteristic feature of progressive supranuclear palsy is really eye movement problems. So people have difficulty with their saccades. Those are the fast movements that now enable you to flick your eyes around the room. And saccades become slow and then actually become very restricted in movement. So they might not be able to move their eyes up or down appropriately. And if they do, then it's very slow. If that's the case, then what we can do to try and assess that is we can use what we call the vestibular ocular reflex, where you ask them to focus on something and then you move their head around, and actually their eye movements are much quicker and in keeping with your the movement of the head, than they would be if they did it themselves. And that's where the supranuclear palsy aspect of their name comes in, because it's a problem with voluntary movement and not reflexive movement. People with PSP often have impulsivity, so they will do things impulsively. For example, they might fall every time they stand up. They hear the doorbell ringing and they'll suddenly shoot up from their chair and try and go and answer the door, which is what they've always done. But that impulsiveness is a characteristic feature of PSP as well, and often the bit that people find most difficult, so family find most difficult, and they have executive dysfunction, which often the family can just say, look, they're just bloody minded, they're stubborn, but actually it's because their brain doesn't work anymore to be flexible with new information. So they're much more rigid about what they think. They have social cognition deficits, so they might not spot if someone is angry or sad or happy. And that's quite difficult for carers when they're looking after them and they come in angry or upset and they can't really recognize that emotion. And they often have depression and apathy. So that's how the textbook describes someone with PSP and someone with corticobasal syndrome. I thought it might be useful just to spend a couple of minutes looking at a video showing how quickly someone can deteriorate with PSP and the kind of problems that they have. So I'll play this video. It's a few minutes, and this person, unfortunately, and this is with permission of the family. In fact, the express request of the family. This person effectively had onset of the disease and then passed away 6 years later. And so roughly every 30 seconds of the video is a year in their life. So let me show that for you.
Look here when it went to #1. And I thought, I'm sure there was a person would take it to look at it. Stand there, please. Pose for me. Come on, do some cheesy photographs.
Can you tell us sort of when your problems started and how it started from your point of view? 5 years ago. And so much my right. Couldn't happen. This
Oh. You're right. You're fine. What were you saying about grief about? I understood. Do you want to have a look at your garden while the still light's there? Yeah? Right, so what's in your hand, sir? How do you tell me what that is in your hand? Good cat.
So, the textbook definitions of PSP are not just a reflection of what they say, but they're also hopefully that video shows you what it means to patients and their family and the difficulties they have in trying to manage the disease as it progresses. So looking at quality of life, this is a graph showing quality of life of a range of different conditions. So on the right, you can see that there are people who are just general population at the top. And then you can see different conditions, so including stroke, halfway down, where people have a slightly worse quality of life, and then ataxias. And what's important to point out is that PSP sits right at the very bottom. So they have the worst quality of life of all of those conditions that you can see there. And it's not just the people with PSP, it's also the people that look after them, so families and carers. And 80% of patients are cared for by their spouse. And so 70% of those spouses look after the person with PSP or CBS 80 to 100% of the time. So hardly anyone that gets support for that. And this is a worse carer burden and promotes increased depression, even compared to people who look after people with Parkinson's disease, and is a similar carer burden to people who look after people with Alzheimer's disease. And they have a median score on the carer quality of life scale of 55 out of 104. And carer quality of life worsens in line with the patient. So as the patient's quality of life worsens, so does the carers. And the carer's quality of life also worsens as the disease worsens. So there's a real difficulty here for people. So clearly, I've described the diseases. I've shown you a video of how PSP, at any rate, progresses. We have talked about the quality of life, but in today's NHS, we need to be more hard-nosed about things, perhaps, and show the NHS why they need to care about things, apart from just the usual aspect of it's just humane, much more humane and ethical to look after people with these terrible diseases. So this is the economic cost. This was carried out in 2011 of different diseases. So you can see on the left, schizophrenia was relatively reduced, and multiple sclerosis was more, Alzheimer's disease and MSA, multiple system atrophy, more. Perhaps it's not a surprise that PSP is even more money to look after someone with PSP. And that's the total cost, including carer costs, which is often provided free of charge by the family and spouse. But if we think about inpatient costs, around 40% of costs were thought to be inpatient costs. So if we take the prevalence of PSP and think about how much that would cost the UK as a whole in 2011, so inpatient costs in 2011 was £78 million. So not a small amount of money. The latest, there is some later research looking at Israel, that's from this year. And in Israel, they looked at costs in US dollars for people with PSP in the year before, which is the top graph, and the year after diagnosis, which is the bottom graph, compared to the general population. So the general population is on the right of the graph, the person with PSP is on the left. And you can see that the green is hospital inpatient costs. And you can see that the green costs are much higher than it is in the general population. Outpatient visits are slightly higher than the general population, but perhaps not as greatly increased. And looking at how the cost of that is varies over time, there's a series of graphs here. So time since diagnosis is the x-axis, or along the bottom, and various measures are on the y-axis along the side. And if you look at the top left with the red line, this is the overall medical expenditure over the course of the disease. And you can see that it steadily increases, increasing most at the 10th year. And everything else seems to decrease. All the other graphs seem to decrease, apart from hospitalization days, which is the top right graph, and that increases, suggesting that it's actually the inpatient costs and the cost to the hospital that is the increasing part of the expenditure that we spend. So what should we do about people with PSP and corticobasal syndrome or degeneration? So firstly, there are no statutory guidelines. So the government doesn't stipulate to us what we should or should not do. All it says is the normal guidelines. And there are best practice guidelines. And the best practice guidelines are from a range of different people. So there's the National Neurosciences Advisory Group, which have determined a clinical pathway for movement disorders. There's the Right Care Toolkit, which talks about progressive neurological conditions. There is the PSP Association Professionals Guides, and you'll hear more about the physio guides later. And there are guides for the GPs. And there are also prominent papers in Frontiers in Practical Neurology, which and other publications looking at how experts would treat people with PSP and CBS and what we think is useful. The important thing here is that those are all guides. They have no statutory weight. So if an NHS trust is under special measures or struggling with money and needs to cut costs, there's nothing to say that it's not going to take a good service and cut its output because they can't afford it anymore, or that if a interested clinician or a motivated, passionate team say, look, we really need to treat these people who have this terrible disease in an appropriate way, there's nothing to say that the trust can divert funds from somewhere else to provide that service, because they're struggling trying to just keep the service afloat, every service. However, one of the ways that we could maybe think about that is to think about what evidence would we need to enable the NHS to form statutory guidelines. And the Motor Neuron Disease Association have, a few years ago now, found that there has been enough evidence for them to ask NICE, the National Institute for Health and Clinical Excellence, to look at the evidence and then make statutory guidelines, which all trusts then have to look at how they are treating people with motor neuron disease. And one of their findings was that a multidisciplinary team with physios and occupational therapists and speech language therapists with accelerated access to wheelchair support and clinicians such as palliative care clinicians and neurologists should work together to provide care for people with motor neuron disease. And as a result of that, trusts all over the country have had to look at their services and see how they can best provide that service. So that might be one route for us to try and stipulate that. What we could do, though, is we could have a look at our service in Southampton as an example of a service that we might want to try and institute around the country and how we might approach things. And this largely uses the guidance that I've stipulated on this slide to look at how we might try and institute that in Southampton and Wessex. So if we look at the progression of PSP and CBS, the initial stage is diagnosis. So diagnosis, it's hard to quantify the benefits, but all the guidance recommends that we try and give an accurate diagnosis as early as possible. I mentioned earlier that there are drug trials, and one of the issues about drug trials is that you can't obviously provide a drug trial if you don't know whether they've got your disease or not, the disease that you're looking at, so PSP. So early diagnosis is essential. All drug trials are probably going to arrest the progression of the disease at best. They're not going to reverse it. And so really you want people to be having the treatment or trialing the treatment when they're very early in the disease so that they actually have a really good function going forwards. Having a diagnosis means that they can plan for the future. They can manage how they and their family are going to cope with the disease. And it helps the clinicians who are looking after them, both in the hospital and in the community, to try and manage them appropriately, and enables them to do advanced planning. And largely, people recognise what their diseases are. So this is a referral that I got of a lady who said that she was concerned that her symptoms only started a year or two ago, and she was only diagnosed a year ago, but her symptoms deteriorated quite rapidly. She doesn't feel that she's responding to the dopamine because she was diagnosed with Parkinson's disease, and she was worried that there was an alternative diagnosis. Often people will go to a PD support group and they will notice everyone around them are not changing, but people with PSP and corticobasal degeneration or syndrome will go there and notice that everybody that they are changing quite quickly and not staying the same as their peers. So that's diagnosis. Early management then. So the first thing that we did when we set up our clinic was have a clinic coordinator. So a clinic coordinator is someone who can provide advice for people with the disease and their families in between appointments, so that they're not just waiting for 3 months or 6 months or 9 months for the next appointment, but if they have a question, they know who to contact, and that person can then provide them with referrals to the people that they need to see. So, for example, they might find that they're having difficulty with coughing when they're drinking, and they can ring one person who then says, "Oh, I think you need to see the speech language therapist, I'll refer you." So in other conditions, patient report most difficulty with coordination. There are a number of different agencies out there that provide different means of support. So for example, you might want a social work employed occupational therapist who will provide aids inside the house, or you might want a community neuro-occupational therapist who will provide you with rehab and other advice. And knowing the difference between occupational therapy is quite difficult sometimes, even for clinicians like myself, let alone patients who are just struggling because they just can't do something. In motor neuron disease, a clinic coordinator led to increased survival and slower functional deterioration. So not importantly to note that it slowed down the rate of the disease progression, but it meant that they could do things for longer. And it also decreased hospital admissions, long-term neurological conditions, a clinic coordinator improved quality of life, and support also was found to be protective for carer burden in Parkinson's disease, not surprisingly, because people know who to turn to and they can get advice straight away. As with most of the things I'm going to tell you, there's little objective evidence in atypical Parkinsonian syndrome, so PSP and CBD or S. However, when we set up our clinic, like I said, the first thing that we did was we put in a coordinator, and we compared quality of life for patients before and after. So the blue is 2017, the orange is 2018, and the bigger the graph downwards, the worse the quality of life. And you can see that actually after the clinic coordinator started, both for patients and carers, the quality of life, while still bad, did seem to improve or level off. We also, thinking about the NHS Trust, looked at emergency department admissions, and while there is some caution regarding this, actually 2017 ED admissions were higher than they were in 2018. So people were admitted less. So thinking about physiotherapy, and you'll hear more about physiotherapy in particular later on in the day from Jade, Donnelly, who happens to be our clinic coordinator and a specialist physiotherapist. Physiotherapy, we all think that physiotherapy has a general benefit to rehabilitation. That's why we suggest it for lots of conditions. And the aims for physiotherapy are better mobility and fewer falls. But it's unclear which strategy is best to use, and there's little objective evidence, as I've said, for this. However, what we do know, and we had a summer student working on this, is that if patients are admitted, we know that they deteriorate faster and need more care afterwards, largely because they don't do the same activities that they do at home when they're in hospital, and they come out of bed less, their function degrades. And so we found that looking at the PSP rating scale, a marker of function in PSP, that decreased, so it got worse by 17.6 for people who admitted compared to 12 in 2 people who were matched who weren't admitted. Occupational therapy. So again, there's limited evidence, but there has been some benefit in patients with multiple system atrophy, which is another Parkinson-like condition, which has some similarities. In corticobasal syndrome, often people do have what we call dystonia, so they have increased rigidity, and they can have increased flexion in their hands, which can be really hard to deal with, and I'll show you a picture in a second. And splinting, so putting something in to keep the hand open, and stretches to try and extend the range of the fingers can help to prevent contractures in corticobasal syndrome. In brain injury, again, there's limited evidence in PSP, but in brain injury, a review suggested that in similar conditions, occupational therapy helps keep that range of motion. And occupational therapy is generally recommended, and this is what we're trying to avoid. So people with increased tone in their hands where they can't extend their fingers. And the worry is that their fingers are so flexed that their fingernails start growing into their palm. So speech and language therapy. Speech and language therapy is obviously useful. We feel it's useful. Lots of experts have suggested it's useful. Again, there's no objective evidence. But the things that we might suggest people go and see a speech language therapist for is voice banking. So as people start losing their voice, we might want to retain that voice, both for legacy, so that people can hear them as they were, but also so that if they need to use other communication devices like an iPad or other machinery, that their own voice can be speaking as opposed to an artificial voice. In corticobasal syndrome in particular, they often can have language disorder, so that they start having difficulty finding the words that they need, using the words appropriately. And that aspect of communication could be looked at with a speech language therapist. Clearly, the other aspect of communication which we're much more used to is people slurring their words. So it's the correct word, but it's just slurred and difficult to understand. And speech language therapists would also try and work with them give them exercises to try and improve that communication. They often have difficulty with swallowing, and speech language therapists and a dietitian would look at how they're swallowing, try and provide aids such as thickeners to try and improve their swallowing, stop it going down the wrong way into their lungs, and decrease aspiration, and hopefully maintain their weight through a dietitian. But we'd also think about other things going forwards, which I'll come to in a second. So looking at the progression of PSP and CBS, we're now coming to complex management. So complex management is thinking of things like power of attorney. What you want to do is you want to make sure that, and again, this goes with an early diagnosis, that you can make plans for the future. So who would enable them to make decisions or make decisions on their behalf if they're no longer able to communicate that? Should they have a feeding tube? So some people decide they do want to have a feeding tube, some people decide they don't. But ultimately, my view is that it's the person with a disease's decision to make in conjunction with their family, and that decision should be made early or as early as possible. Equally, you want to think about resuscitation. So what resuscitation, would people want to be for resuscitation? And if so, at what point would they make that decision? And you want to have those discussions early. Sorry about the background noise here. You want to make other advanced care decisions as well, such as do people want to have antibiotics? At what point do they want to have intravenous antibiotics? Do they want to come into hospital? And these issues may have to be discussed early before communication becomes more difficult. But again, there is little objective evidence, although there is more evidence for palliative care. So palliative care has been found to be beneficial in a range of different conditions, including in PSP and CBS, where a majority of patients stabilized or improved after admission to a hospice, where they could get focused care with people that know them in a perhaps a non-anonymous environment where people know them already. In long-term other conditions, such as motor neuron disease, then palliative care improved quality of life and their interaction with pain and bowels and sleep. And in multiple sclerosis, fast-track palliative care decreased care burden and cost. So those are all that's all evidence to try and help trust to see the benefit of liaising with these services and trying to provide these services for these patients. So the general principles then are that clinicians, which is doctors, therapists, nurses, are nervous about seeing people with progressive supranuclear palsy and corticobasal syndrome. Patients progress quickly, but self-management and education are thought to be helpful, and patients and families appreciate involvement in research. And I'm hoping that today's study day might help alleviate some of those anxieties for those of you who are less familiar with PSP and CBS, and you might see that actually the things that you do on a daily basis for other people with long-term conditions is broadly similar for people with PSP and CBS. So how would you help to try and treat people? Well, it's important to have lots of help if you can. So this is something that PSPA did a while ago, looking at all the different support services that would be helpful for people with PSP. You can see that specialist nurses, neurologists, geriatricians are top right, and the GP and the PSP Association are central. But there are also other people like specialist care advisors, clinical psychologists, palliative care teams, people with equipment, social workers. And so it's important to try and build up those systems, which I'm sure you do, just to try and make sure that you can call on those people when you need them. So how do we provide a service for people with PSP and CBS in Southampton? So we try and look at the whole of the pathway of the person with PSP and CBS, so from diagnosis through to the later stages with palliative care. So we are a regional clinic, but it just so happens that me and my colleague Luke Massey, who also runs the service with me, I work in Salisbury and Southampton, he works in Dorset and Southampton. And so we can see people from outlying regions, provide care centrally in the Southampton clinic in the early stages, involve people in research, and then as the disease progresses, we can then see them more locally where travelling is a bit harder. And locally, we have joint clinics where we would see people with palliative care teams. So going through that a bit in a bit more detail then. So we serve Wiltshire, Dorset and Hampshire. We have a population of around 2.3 million. 2 consultant neurologists, as I said, me and Luke Massey. We see about 100 people with PSP and 26 people with corticobasal syndrome. So we're one of the larger clinics in the country. We have a clinic coordinator who you'll hear from later called Jade Donnelly. And we try and be multidisciplinary, and that's purposefully trying to coordinate things with people in the community. So what we didn't want to do is we didn't want to have a specialist team inside the clinic, because then the community therapists feel disenfranchised and refer people to the specialist team in the clinic rather than trying to help the patient closer to home. What we try to do then is that we liaise with the community teams before and after clinic, and they do come and sit in the clinic if they want to and if they have time. We've also just got a network grant from the PSP Association where we're able to provide support and training to clinicians. So we have a 2-year rolling program of support for different groups, so physio and OT, for example, or speech language therapy and dietitian. And we also provide a network MDT, so we can provide support to people with a monthly virtual call where people can present patients that they're struggling with and provide advice from me and others who have built up a bit more advice with PSP and CBS. That's not started yet, that's due to start in January. We also have really strong links with palliative care, so we have local joint clinics, as I've said, in Dorset and Wiltshire and Southampton, but we also try and include them with an MDT every so often, every month or two, where we talk to them about patients that they have and things that they're struggling with. We also have research registrars. I think someone is unmuted. If they could mute themselves, that'd be great. So we also have research registrars for research, and we also have clinical trials assistants who try and involve as many people as possible in research. And we have a range of research. So we have questionnaire-based research, which people can do just by filling in a questionnaire, which is really helpful to see if there's any benefit to the service that we provide, through to commercial drug studies, where people have to come in every few weeks to have an infusion of a drug and ratings that may last for 24 hours or so. And that's obviously up to people to decide whether they want to do that or not. So that's our central clinic. We have a joint clinic in the district general hospitals such as Salisbury, where we have a 2-monthly clinic where we see people with motor neuron disease and atypical Parkinsonian syndromes. We don't see them. We have what we call a virtual MDT. So we'll discuss everybody with these diseases with the community teams and speech language therapists and palliative care. We'll go over what the difficulties might be, and then see how we can find a solution for the therapists. And then after that virtual clinic, which is an hour and a half, we'll then see people, the people with perhaps the more difficult issues, or where we need to see them jointly. We'll see them afterwards, and we have slightly longer appointment times for that. And it enables us to introduce people with these diseases to the wider team early, and have strong links early on in the disease, so that people know them already. In terms of research, we carry out phase 1 to 3 registry studies, phase 1 to 3 studies and registry studies, just to give you some knowledge of that in case you're not familiar. So phase 1's studies are the very first studies. So you have a new drug, you're not familiar with whether it works or not. You've never tried it in a human, you might have tried it in a mouse. So what you do is you try it in people and you monitor them very closely. Phase 3 studies are studies where you've tried it in humans, you've tried it in people with the disease, you think it's work, you think it's safe. You've got some early studies, phase 2 studies, to see that it's there's early signs that it might be useful, and a phase 3 studies where you are working to see if there is enough evidence that it works for the NHS or other agencies around the world to adopt it as a treatment. And registry studies are essentially cohort studies or studies where we are asking a large number of people for information about themselves to try and improve our services, or to have genetic studies, for example. So currently we have a few phase 2 studies which we're doing, and we have a few other studies that are in the pipeline to start with people with PSP and CBS. Unfortunately, corticobasal syndrome, as it's difficult to predict the actual pathology in the brain and therefore the protein that people might have, it's sometimes quite hard to have commercial drug studies in corticobasal syndrome. But we would be keen to try and carry that out if they were more available. So in the future, we want to investigate the benefit of specialist clinics and services, and we have a questionnaire study that we do essentially within Southampton to see if we can spot any differences in our services that might help us to understand that a bit better. However, we're also collaborating with Surrey and Jeremy Stern to look at how we might compare places that don't have a specialist clinic with people that do, and see what the benefits are more starkly. Also trying to work on studies that would look at better diagnosis, so ways that we might be able to look at those proteins that cause the diseases directly, and hopefully enable earlier diagnosis. Excuse me. And we're also looking at, we put in for a small grant, looking at to see if we can see any benefit to feeding tubes to people with PSP and CBS over time. So if we put it in early, does it confer a benefit as it does in other diseases? So how do we persuade our trusted supported clinic? Well, as I've said, there's a lack of objective guidelines and evidence. There's no statutory guidelines. But I think hopefully over this presentation, I've tried to show you the difficulty that people have with these diseases, the terrible nature of the disease and how it affects them and their family, and how it affects the NHS and the health service as a whole, and how actually providing care, which is general care largely, as you might do for other long-term conditions, might streamline their care through the system, might streamline other clinics, so general and movement disorder clinics that we all have, and enable those to run more smoothly as well, because we're cohorting people into different areas, different clinics, and hopefully providing that care will reduce hospital admissions and costs, which is what the trust want, reduce admin time of inquiries, so that that you can handle those more efficiently, and more importantly for me, and I'm sure for others, would enable people to have a better quality of life while they're enduring this disease, and hopefully open up the possibility that we might be able to find something in research that would make their life better and perhaps even stop the progression of the disease. So I just want to say thank you. A clinic like ours and research like ours cannot run without a whole host of people that work behind the scenes for us. So most importantly, Luke Massey and Jade Donnelly. Jade, you're going to hear from later, who are the neurologist and specialist coordinator and physiotherapist, respectively. Zoe Rushant, my secretary, and Ruri, our long-standing clinic nurse who does all the measures for our patients as they come in. Registrar researchers who've worked on some of the information that you've seen that I've presented, and medical student researchers that have done similarly presented some of that information that you've seen in this presentation, and our collaborators. And the PSP Association has given us grants, and the Wessex Neurological Centre as part of the University Hospital Southampton, who supported us to set up the clinic and have supported us to carry it on. And I think we're probably not taking questions, but if there are questions in the chat, I think we have a few minutes if Paul wanted to direct those to me.
Yes, we do have, we've got about 15 minutes actually, Boyd, so, and there are a number of questions that have come up. So firstly, just thank you for a great presentation. You know, even with close proximity to the condition, it's easy to take it for granted. And when you talk about those statistics around, you know, the occurrences in population, the mean survival rate, and then, you know, the quality of life, I don't think I've ever seen that statistic. And, you know, we've seen lots of statistics that we share. I think that really hit home for me. You know, the importance of what the clinic and what you do. I thought that was just outstanding. We've got a number of questions, so I'm going to read them out on behalf of the people that put them in the chat. So the first one is from S. Such, and that question was, what was the name of the test that you run to look at the eye movement? I heard vestibular in there, but didn't quite catch it, and it was very interesting. So if you could,
okay. So I can maybe show you, that'd be easier. So it's called the vestibulocular reflex. So what I do is I ask people to look up, and I ask people to look down, and their eye movements are usually quite slow. So they might, so just to show you my eyes here, if people can see me. So you can look up and it's really slow, and then you look down and it's really slow. So what you do is you move the head from side to side, and you ask them to look at one place, up and down. And actually, that's called the vestibulocular reflex. It's a very primitive reflex. It only has 1 or 2 nerves in it, and that enables you to keep something in focus when you're moving, when you're walking or talking. And that movement means that they can move their eyes much quicker than they can voluntarily, and that suggests that it's that the problems that they're having with their eyes is due to the problem with the brain as opposed to the problem with the eye movements themselves.
Fantastic. Thank you, Boyd. Next question from Dr. Robert Lambourne, which was, where is CBD on the quality of life scale?
So we don't know, because there's no evidence. So unfortunately, that that graph was a graph from a study, and they didn't look at CBS, I'm afraid. Now we are collecting some of that data, and hopefully we'll have some of that data to be able to mark out where CBS is, and we're collecting. It's important. We have measures that are directed, focused particularly for PSP and CBS or CBD, so quality of life scales, but of course no one else has that. So you don't do a PSP quality of life scale in someone with a stroke or Huntington's disease or Alzheimer's disease. And so it's important to try and collect the generic measures for people with those diseases as well as PSP and CBS. We are doing that, and hopefully in the future we'll be able to provide some information about that.
Okay. Thank you. Next question, and this one was a hot topic on the chat. You probably didn't catch it, Boyd, but you'll know it's a hot topic because it always is. And this comes from Lauren Muir. Why do people with PSP, or indeed CBS, not qualify for continual healthcare funding, or CHC?
Okay, so So it's not that they don't qualify. So continuing healthcare is needs-led, and at least the theoretical limit is: is someone so do they have a health condition which is so difficult to manage that they need healthcare workers and not social care workers to look after them? So do they need a nurse rather than a care assistant to look after them? And at least in theory, the assessment process looks at the level of health need and asks, could this be given by someone off the street, essentially working for a care agency, or does this have to be a nurse? Now, the result of that, unfortunately, is that then all payments, all care is then paid for by the health service, because it's deemed that the health service needs to provide staff to carry that out. In effect, there is a really high threshold because clearly there are lots of people out there with Alzheimer's disease and Huntington's disease and many other conditions, Parkinson's disease, where they might feel that they need lots of care, and the bar is set high. I have my own personal views about that, which don't really align with that, but the bar is set high, and in effect that can vary from place to place, so from different postcodes to different postcodes. If you are very young, so if you're 45, for example, and if you have diseases which are similar to someone who is 75, then it seems, at least cynically from my point of view from a distance, that you're more likely to get continuing healthcare. If you have a cancer diagnosis or a rapidly progressive diagnosis, then that also suggests that you might be more likely to get it.
Karen is one of the Parkinson's nurses. We had a telephone consultation with you today.
Sorry,
sorry I can't get hold of you.
So
we'll rearrange
someone's
the appointment
unmuted
for you. Thank you. Bye-bye.
Sorry, just at this moment, Boyd, it's worth letting people know, if you could just double check your mute buttons to make sure that you're switched off, that'd be great. Appreciate that it flips on and off.
And the other thing is that some places, some postcodes do seem to suggest that some places will give continuing healthcare a little bit more easily than others, although universally it's hard.
I mean, could I just build on that, if it's okay, Boyd, from my own personal experience, having gone through it for CHC, there is a real complex process to go through, points-based scoring, and some of it can be open to interpretation. One of the things I would say is that the PSP Association provides guidance on CHC. It's on the website. I'm sure Carol's in the background could possibly put the link on there. And so that's one of the things. I think the other thing as well, certainly it's, as we know, people with these conditions will often say that they're better than what they are, or life is better than what it is. And, you know, CHC funding should be about your worst ever day, because that's the reality of what it is today, not your best day. And your worst ever day as it currently stands is likely to be your best day fairly soon. And of course, that's one of the other challenges. The process is long, yet the deterioration is quick. And so thank you, Carol. She's put that on the chat. So
thank you, Paul. Those are both very good points.
So keep going would be my view, and please do go to the look at the guidance. It certainly helped us. I'm going to switch to the next question, which is from T. Gaskin. Is the clinic a coordinator, admin, or a nurse? You may have covered that in the presentation. There's loads you shared. What's your perspective?
So usually it's helpful to have a clinic coordinator who is clinical. So it doesn't have to be a nurse. It could be a physio, as in our case, or occupational therapist, but someone who knows the healthcare service as a clinician, who would be able to provide some clinical advice, but also then signpost and refer as appropriate. We also have a secretary, essentially, who can organise the admin bit. So, you know, someone says, "I've not been, my appointment's been given to me for 2 years' time, and I thought you said 3 months." You know, it's usually a mistake from the bookings team, and then they can sort that out. But there's two aspects, I guess. But the clinic coordinator should be someone who's clinical.
Okay, thanks for that, Boyd. I mean, and again, from personal experience, you know what it's like with all of the different appointments that are going on. You know, as people get older, their diary management skills are maybe not what they once were, and having one person to talk to can be just so, at a personal level and an organizational level, can be so valuable. So something I really kind of picked up in your presentation. Last question is from Liz Taylor, which was, are there any particular hand splints that have been helpful? They've only got access to banana splints and they don't work very well.
So that sounds like a very focused therapy question.
Which Jade could answer probably a bit later.
Which Jade could maybe answer later, yes. She happens to be in the office with me, and so she's nodding, so you can ask that question at the end of that one.
All right, okay. I think that's it for questions. We're doing okay for time, so any final call for questions? If you want to put one on the chat now, we'll ask maybe one or two more, as we don't have this opportunity to hear from somebody like Boyd that often. So whilst we've got you, Boyd, we're going to make you work hard. So any final questions, put them in the chat, because we've got a few moments. So let's make
Dawn, who is our OT, has put in that carrot splint is sometimes helpful, and that's a splint that looks like a carrot, and you pull it through, and it may just basically means that it will force open the fingers as it goes down. It's usually very soft, so it doesn't hurt, and so that's something we use to try and help the fingers come up. But there are a range of other things. There are kind of sheepskin splints and other bits and pieces that are of varying helpfulness.
Right, so we do now have another question which come up on the chat, which is, how much speech therapy and dietetic time do you have funded for your clinic?
So again, this was something that we decided at the beginning. Rather than having a speech therapist and a dietitian in clinic, we try and liaise with speech therapists and dietitians around the region, because otherwise what happens is someone goes to their local speech therapist and said, look, you know, I'm coughing a bit more, and they say, well, you've got PSP, you need to go and see, you're the specialist PSP speech language therapist in the clinic, which just delays things. And actually, it's the same process that we would do for someone with PSP as we would for someone with a stroke or Parkinson's disease or anything else. It's an assessment and then some advice. So we don't have any speech and language therapy or dietitian time within our clinic, but we do work really hard to try and liaise with people in the region.
Again, that kind of local orchestration being absolutely critical. Next question, I'll probably cut the question here. Well, we're doing okay, actually. But Michelle has asked a question, which I think you mentioned the importance of diagnosis and early diagnosis before, Boyd, which is, how long does it take to diagnose PSP, and why is it so difficult to diagnose?
So that's also a very big question. So thanks for asking that. So the practicalities are that it can take about 2 or 3 years to diagnose someone with PSP, largely because we're waiting for the eye signs to come out. Not always. So I can sometimes make that diagnosis before the eye signs, but you're on shaky ground and you can't be absolutely sure. And it's not a disease that you want, a diagnosis that you want to make lightly. The difficulty is that in the early stages, someone with PSP will say, well, look, I'm falling. I don't know why I'm falling. And if it's only that aspect, then it could be because they've got Parkinson's disease, it could be because they've got back problems, it could be because they've got neuropathies, it could be for any number of different causes. And the difficulty is that you have to try and find those aspects that point you towards PSP specifically. And that can be what's sometimes hard. And that's why we're working with others and others working around the world to try and find blood tests or spinal fluid tests that would help us to make that diagnosis earlier.
And I think we also have provided some red flags guidance from PSP Association. So again, Carol, I'm also making you work quite hard in the background there. We've got some support for health social care practitioners around red flags for PSP and CBD. So we'll put the links for those on the chat. If you're not aware of them, then you'll be then aware of them and you can access them and share them, of course. Last one is, are there any respiratory symptoms for typical PSP patients?
So respiratory symptoms. So in other conditions like motor neuron disease or multiple system atrophy, often there are respiratory difficulties that are specific. so weakness of the muscles that allow enable you to breathe. That's not quite the same in PSP and CBS. However, because the swallow is disordered often, you can get a very subtle or long-standing chronic low-lying infection in the lungs, which can mean that you're more short of breath or damage the lungs from aspiration pneumonias that occur. As the disease progresses, equally, people become weaker in their arms and legs, and so they're much more short of breath as they're doing less exercise and able to do less activities. And so people might become short of breath for various reasons. It's not quite the same specific reasons as you might find in other conditions.
Okay, thank you, Boyd. So I think we might let you off the hook as we transition into the next speaker. A phenomenal presentation, great load of information, really great questions. What I would remind everybody is that the video and this session will be shared with everybody after. So that will be up on the website a few days after we finish anyway. So certainly I'll be going back and looking at some of those numbers, in particular the cost of the condition. I thought was quite interesting again, Boyd, in terms of what that looks like compared to others. All right, so thank you again for Boyd's presentation. We're now going to move, and I'm going to share my screen just to go back to the agenda. So we are now going to have a presentation from Dr. Susan O'Connell. So Susan, are you there and ready to share and ready to go? So I do know, talking to Carol earlier, that Susan was literally coming out of clinic directly in to do this. So let me just check in with Carol that Susan is here and ready. If not, we will take a very short stretch break. We have Susan. Excellent, Susan. So I've stopped sharing the screen, so you should be able to share your presentation.
Hi there.
I'm going to put myself on mute.
Excellent, lovely. Hi everybody. Sorry, I was cutting a bit fine joining from clinic this morning. So sorry if for keeping you waiting. And I will just share my screen. Although I'm used to using MS Teams, I'm just having a little share screen that's there. Sorry, it was in bright green in front of me. So I'll just make sure people can see that. Okay.
We're seeing it fine, thank you.
Is that okay? Lovely. Okay, are you happy for me just to start? Sorry, you just waiting on me joining basically. Okay, lovely. So my name is Dr. Susan O'Connell. I'm one of the consultant clinical psychologists who work here at the kind of INS centre in NHS Greater Glasgow and Clyde. So thank you very much, first of all, for inviting me along to speak today. And I know there's a huge number of attendees, which isn't intimidating at all. So hopefully today there's some things of interest to you in this presentation for you. So I'll talk a wee bit with overview of today's presentation. I want to, I suppose, probably just use it as a wee bit of a platform, maybe just to kind of speak a wee bit about the role of neuropsychology. It may not be a service everyone has access to or has came across before, or maybe just not really sure what it is that we do. I won't go on a huge amount of time about it, I promise, but I just thought that might be helpful as a kind of starting point. And it might also just, I guess, orientate us a little bit about the role psychologists have when trying to assess and understand cognition in relation to neurological conditions. So I'll speak a little bit about that very briefly. I'll also maybe just spend a very, very short amount of time just orientating us to the neuroanatomy of PSP and cortical basal syndrome, which are the two main conditions I'll speak about today. And the reason I'm doing that is really just to, I guess, highlight why it is we see the cognitive symptoms we see in these conditions. I'll then talk a little bit about the differences between the cognitive symptoms between cortical basal syndrome and PSP. I'll talk a little bit about how they overlap as well. And because I am a clinical psychologist, I will talk about mood a little bit, but I promise I'll kind of talk about how it relates to cognition as well, and the importance of considering that. And then we'll spend a wee bit of time thinking about assessment of cognition, if that's something, so you, I guess, have a wee idea of what that might look like should you have any patients you think could benefit from cognition being assessed. Talk a little bit about management of some of these symptoms that we may commonly see, and then just a little bit of kind of signposting, maybe of where to go if you have any sort of concerns or questions relating to cognition or mood as well. So hopefully that sounds okay. And am I right in just saying I think I've got 40 minutes? Is that, yep, okay, so that's best. I'll keep yes, thumbs up, so I'll keep a wee eye on time. Okay, so very briefly, so neuropsychology, who are we, what we do, and I think a lot of times patients will come to see us and have a bit of an uncertainty of what they're walking into, because it's not always well known what clinical psychologists do. And I see a lot of patients through the Atypical Movement Disorder Clinic that I'm part of here in Greater Glasgow and Clyde. So we work really closely with our neurology colleagues, our clinical nurse specialists, our HP colleagues, and neuropsychology kind of fits within that team, either contributing to the diagnostic process, assessing cognition as part of that, or we also have a big role at supporting individuals and their families adjusting to living with conditions like PSP and CBS. And ultimately our role in a nutshell is how a known or yet undiagnosed neurological condition impacts on someone's cognition, emotions and behaviours. And that's really it. It's not really anything kind of more complex than that. Neuropsychologists are first and foremost clinical psychologists. So we train through a DCLIN project program. We're clinical psychologists, so we're trained in assessment, formulation and intervention of mental health across the age span, and there's subspecialties that we then go into work in, and one being neuropsychology, where we use our kind of breadth of knowledge of kind of mental health and presentations, but also kind of bring into that our understanding of neurological conditions and how that also may affect someone's mental health and well-being, and we also have a role and understanding how these conditions affect someone's cognitive abilities and the impact that may have on their life day to day. So really when it comes to kind of assessing cognition in particular, or assessing, I suppose, any patient that comes in to see us, we hold a really broad overview of all the different factors that could be relevant through speaking with the patient themselves. We pull lots of information from our neurology colleagues, MRI imaging reports. We get collateral information from family and friends. And I don't know if you can see that the way my slide, where that wee camera is, I'll maybe pull it down. But this wee corner here is basically saying psychometric data is another big part of our role, where we carry out cognitive assessments with individuals. So it's really important for us as neuropsychologists to understand different neurological conditions, understand the brain areas that are affected by those neurological conditions, and that really gives us a lot of information and ideas of, well, what cognitive symptoms may we expect to see. And when we're carrying out the cognitive assessment, we've got some hypotheses to what maybe leading differentials may be, and that's true for patients that come through the atypical movement disorder pathway. So we really need to know how the conditions affect us. When we do the cognitive assessment, is it making sense to us? Are we seeing the cognitive symptoms we maybe would expect to see? If not, why not? And that's where our kind of broader skills and assessment, looking at also like things like mental health, come into play. So that's sort of really the role of clinical psychology, how we sort of approach assessment there. So like I said, it's really important for us to understand the conditions of how they affect the brain. So I'm just going to have a wee brief, very, very brief overview of kind of different functions of the brain. And then I'll relate this to PSP and CBS as we go, and sort of link it into why we see the cognitive symptoms that we do. So I apologise if this is really obvious to people, and hopefully I'm not going over anything. It's very, very simple already, but it was just to give a wee brief orientation. So I'll talk today about kind of cortical regions of the brain as we're talking about cognitive symptoms. So this is just a kind of very brief overview of the main lobes of the brain and the cortical functions that they hold. So it's quite nice in colour. So we'll see the frontal lobe in red here, which is responsible for things like lots of different functions, but very, very briefly, like problem solving, judgment, decision making. It holds a lot of kind of responsibility for what we might consider personality, kind of emotional expression, motor planning, and we'll talk a lot about the frontal lobe today. Parietal lobe is another lobe just to kind of highlight there in yellow. So that's responsible for kind of integrating lots of different senses from touch, taste and smell, spatial perception, visual perception. We've got the occipital lobe at the back in blue, which is a kind of visual processing centre. The temporal lobe, which is the front in that kind of tealy colour, which again has a breadth of responsibilities basically. But we think about this being really tied into kind of memory functioning, but also understanding language, and hearing is also a big part of this lobe's function. And at the back, we've got the cerebellum and the brainstem, which is in orange. And the brainstem is another kind of structure we'll just think a little bit about today, and how that may influence some of the cognitive symptoms that we see and the conditions that we'll talk about. So cortical regions are really important for these conditions, because we see degeneration and change in these cortical regions, and that will present with certain symptoms. I also want to just spend a wee bit, very briefly, just really kind of highlighting the importance of connectivity in the brain as well. And I think that's really important when we're thinking about PSP and CBS in particular. And again, it's just trying to kind of get us to broaden our understanding that cognitive symptoms often don't just present because we have very focal specific change in brain areas, but also cognitive symptoms can arise because we've got huge connectivity in the brain. So cognitive symptoms can be quite far, can come around because of quite far spread changes. So the brain is always communicating, it's always talking to itself. And we've got these huge pathways that are kind of represented here very simply in arrows, basically. That just to kind of show us that the brain is always busy. They've got huge, huge tracks that allow the brain to communicate from those kind of cortical structures to structures that sit underneath that. And neurological conditions can often affect both cortical and these subcortical connectivity tracks. And on this slide here, you'll see a kind of wee disc. It's like a kind of pink, dusky pink colour, which represents the basal ganglia, and that's a really important subcortical structure for really any Parkinsonian condition, but really important to what we'll talk about today. And I just want to draw your attention to the arrows that are here. I'm not asking you to make sense of it as such, but just really to draw your attention that quite a lot, all these arrows will kind of lead to that frontal lobe in the brain. So a lot of connectivity in the brain projects onto the frontal lobe, and that's really relevant for some of the cognitive symptoms that we'll see in the conditions we'll talk about today. So I suppose I just wanted to set a wee bit of context about that, so it maybe makes a bit of sense as we go. We'll talk about it in a minute. So I want to just start, I think, talking about cortical basal syndrome, and I want to tease out the cognitive symptoms that we might see that are unique to this particular condition, and then we'll move on to PSP. So for cortical basal syndrome, what I maybe just say as well, that I suppose cortical basal syndrome is a term we'll use. Some people will say cortical basal degeneration. I suppose I say cortical basal syndrome because that's really the kind of term we're given to the constellations we see that make up what we think of as CBS. Cortical basal degeneration is more of what we refer to as the pathology that might drive it, but that's not always true to cortical basal syndrome. It can be driven by different pathologies. So we'll call it cortical basal syndrome today. And within cortical basal syndrome, the kind of cortical regions we'll think about today is the frontal lobe and the parietal lobe. And we'll also think about this kind of frontal striatal network as well, and think about that basal ganglia and how that projects to the front of the brain. So cortical basal syndrome, which you'll all be aware of, it's an accumulation of tau protein greater in the cortical sensory regions in the putamen, which makes up the basal ganglia. It's a tauopathy. A core characteristic of its features an asymmetrical onset of symptoms, and we will often see that in neuroradiology and the reports we see from MRI and SPECT scans. There's certain kind of motor symptoms we'll see that are quite common, such as alien limb syndrome, which can be common in a huge percentage of patients we see, and we think that's due to change in the non-dominant parietal lobe. We'll also see severe demotor apraxia as a core feature of this condition. We can see bulbar symptoms maybe a bit later on in the disease progression. And I think what we're realising more so over time and with more research in this area is that we're challenging that kind of initial idea that cognitive symptoms either weren't present in corticobasal syndrome or presented only very later on as the disease progressed. And what we're now seeing in the literature and what we see clinically and what we know to be true is that motor and cognitive symptoms can occur in equal measure, and even now we're seeing cognitive symptoms can appear very early on in disease progression and sometimes may even be some of the initial symptoms that somebody presents with. So I think it's quite nice to see the literature progress over time to recognise the core feature of cognition within corticobasal syndrome. So thinking a wee bit about the unique profile of kind of cognitive symptoms in CBS and what we might hold in our mind that we're maybe looking for in terms of our cognitive assessment. So language is like a kind of main feature that we maybe see change in corticobasal syndrome. And I've just put a wee screenshot here of a fairly recent systematic review that looks at language in corticobasal syndrome, which can make it quite helpful to look at here if you'd be interested in. So when you look at the kind of central diagnostic criteria for corticobasal syndrome, language difficulties is core to that, and it confirms this kind of cortical involvement that we know is central to corticobasal syndrome. If you were looking at systematic review, we can see there's a kind of consensus here that there's not really just one unique language profile that we see. There's certain changes in language we see that maybe are more common, such as progressive non-fluent aphasia as a kind of more common language disorder that we see in corticobasal syndrome. We think that's because we see sort of atrophy over the pericivilian region. We know that's kind of where the Broca's area is housed. And we know on the kind of right side, that's where we maybe have it's important for emotional processing of speech, like prosody inferences, also integrating language from different modalities. So that's why we see quite a dominant language feature in corticobasal syndrome, because we're seeing change in those particular areas. I guess the profile, like we said, can be quite variable. And I think looking at the literature and thinking of what we see in clinic, that may be for different reasons, maybe a little bit tied in with where they may be in their disease progression. We know corticobasal syndrome can be driven by different underlying pathologies, and there's some sort of conversation around whether a more dominant language profile can be linked to particular pathologies like an Alzheimer's disease pathology driving CBS, for example. And sometimes, because it can be quite variable, there's maybe not always a consensus of how we should be assessing language within corticobasal syndrome as well, to make sure that we are picking up maybe some subtleties of change in language. I think there's some nice papers out there that give nice guidance, looking at more your primary progressive aphasias and language disorders that can give us some good guidance in what we should be assessing. So I think that will only get better. And language difficulties is hugely distressing for patients. It has a massive impact on their ability to communicate to family and friends. They can have a significant loss of confidence and ability to engage socially with people. And it does progress over time and can lead to mutism in patients. And so very debilitating and very distressing cognitive symptom to experience. But it is common and one of the kind of core central diagnostic aspects of corticobasal syndrome. We also know this syndrome is very much associated with difficulties with praxis. So apraxia is a core diagnostic criteria, and it's a higher level cognitive function that requires integration of multiple sensory symptoms. I think it may be a typo there, but they integrate lots of different multiple sensory inputs. And as I say, it's a kind of core feature of corticobasal syndrome and quite characteristic of it. And it's characteristic because of where we see degeneration in this condition. So we see a lot of degeneration in the frontal and parietal lobes and the basal ganglia, which results in disruption in planning, initiation and coordination of purposeful movement. So that's why this is something that's so dominant in this particular condition. It's not a loss of ability. And it's not a loss of desire to perform the action or movement, but it's more just this inability to do so because we're seeing real change, particularly in the kind of parietal lobes. See different types of apraxia, but ideomotor apraxia is really common. So it's kind of difficulty using gestures, or copying gestures, or knowing how to what motor skills we need, or the actions we need to perform to do certain things, such as combing our hair. We can see dressing apraxia, we can see ideational apraxia, we can see eyelid apraxia as well. So there's lots of different forms of apraxia within this condition. And again, it can be really debilitating for people. It can affect preparing meals, it can affect dressing. You know, for patients where that obviously aren't able to always control their kind of eyelid movements, the eyes will close, which can obviously lead to kind of falls risks. It makes it difficult to kind of engage in what they're doing day to day. And I guess when we see patients in clinic, sometimes it's very apparent and we can see difficulties here quite clearly, but other times it can be difficult to assess, and that might be due to other things, you know, particularly on that side of the body, there's a lot of bradykinesia, rigidity, sometimes we might see limb dystonia if present that can make it difficult. So it's something we may not always be able to pick up an assessment, but in other times it can be quite apparent. The other kind of cognitive symptom we often see and pick up an assessment is in the domain of visual spatial abilities. And I think there can be a wee bit of uncertainty around this in terms of maybe kind of earlier literature and research would maybe suggest it's not particularly prominent, but actually we're realising it is quite a feature. I think that paper from Back et al. 2006 is quite a good paper to orientate you to. I think that paper sort of came around from recognising there's not a huge amount of literature that was looking at this particular cognitive domain in this condition, and they were looking at kind of a number of different kind of atypical Parkinsonian conditions, so including MSA, PSP, cortical basal syndrome, and sort of identifying actually all of the kind of atypical Parkinsonian conditions, of those ones I've mentioned, that you will more likely see visual spatial deficits within cortical basal syndromes. And that's linked to, and I suppose it kind of makes sense when you think about that kind of cortical lobe, the parietal lobe, and degeneration there, because we think there's involvement here in the dorsal stream. So what I mean by that is when patients are making sense of what they're seeing in front of them, it comes through the kind of eyes, projects onto the occipital lobe, which is a visual processing centre, and then the brain's kind of got to know what to do with that. And it sort of comes down the ventral stream to let us know what it is that we're seeing. We can name it, we can access the semantic knowledge associated with that. And it comes up through the dorsal stream into the parietal lobe. And that's really the stream that lets us really work out where something is, how we interact with it. And if we have degeneration there, it sort of makes sense we're going to have these visual spatial difficulties. But we've also got disruption in the connectivity there as well. So basal ganglia projecting to the frontal lobe. We know the parietal and frontal lobe also talk to each other. So sometimes we have true visual spatial difficulties linking to the parietal lobe, but we may also have frontal lobe kicking in here, and maybe it becomes difficult for somebody to organise and make sense of what it is they're seeing and how they interact with it. It can be complicated by motor symptoms as well. But this is quite something that we do see in cortical basal syndrome, and is very much linked to where we're seeing change in the brain because of this condition. So I'll talk a wee bit now about PSP, and then I'm going to come back and pull together the overlap between the conditions, because there's some core cognitive symptoms I've not mentioned yet, but that's because we can see them in both these conditions. So I'll just kind of talk a little bit about PSP in the first instance. So again, just to kind of orientate us to where in the brain we may see change because of PSP, we are more thinking now about the kind of frontal lobe, and also kind of structures in the brainstem, particularly the midbrain. So there's not as much impact on cortical structures with PSP compared to CBS. But we do have a big impact in the basal ganglia. So again, we're looking at that connectivity. So as the basal ganglia projects to the frontal lobe, we're seeing change here, and we're seeing it quite broadly across all the different kind of circuits in the basal ganglia. So just very briefly, PSP is another tauopathy, so it's the tau deposition in nerve cells, affects the midbrain, basal ganglia, and frontal cortex. And again, there's some nice papers now kind of looking at correlates between kind of PSP and frontal lobe atrophy, and realising there's more atrophy happening in the frontal lobe than was initially sort of appreciated, and it's not just all about the connectivity. We see a kind of hallmark feature of PSP being the vertical gaze palsy. We think that's related to atrophy in the midbrain in particular. We see a lot of postural instability early on, early falls often backwards, which is a key feature which you all know. There's different phenotypes. The most common is the Richardson variant. And I think between variants, there's not really a kind of distinct cognitive profile between the different variants. There's some core features that we'll see consistently across them. We can see some quite helpful changes on MRI that can be helpful for the diagnostic process of PSP. So the hummingbird sign you might hear people talking about relates to kind of atrophy within the midbrain, and it's quite a kind of key radiological feature. The cortical regions are less atrophic than in CBS. Brain stem's thought to be more so, but we do now know we get this kind of more kind of frontal lobe atrophy than maybe was realised initially. And we get a lot of early bulbar symptoms and kind of falls. And if we have a lot of that earlier on, it's sort of linked with poorer prognosis. So I want to just kind of mention a few different things with PSP. So language change isn't only specific to CBS, but the quality, maybe the type of language difficulties we might see could be slightly different in PSP. So you might still get a kind of non-progressive fluent profile here, but you might also meet patients who also have a kind of echolalic aspect to their speech as well that we often see in PSP. And we think that's maybe due to some of the sort of degeneration of the tegmentum in the midbrain. We think we may have a play here for that kind of echolalic speech. It's not just PSP we see that feature, but we can see it in PSP. We also see reduced fluency, we can see dysarthria, we can also see changes in pragmatics of speech, like turn taking, for example. And I think the echolalia, I think I've seen it quite a lot in clinic. I'm not sure if anybody else here maybe has any thoughts on that as well, but you know, it can be linked to changes in tegmentum, but I think also sometimes it can be a bit of a kind of upset, like repetitive behaviour that can develop more from a kind of behavioural aspect as well. We know there's maybe difficulties modulating speech, maybe more linked to kind of frontal lobe as well. So there's possibly different kind of mechanisms here for why we might see that. But I suppose we maybe see slightly different quality to some of the language difficulties in PSP that may be slightly different from cortical basal syndrome, and the mechanisms behind it being slightly different. This is not really so much like a cognitive symptom as such, but I suppose I just wanted to kind of mention this as being something we kind of see in PSP, and maybe a bit more in PSP, is that kind of emotional ability that is relatively common. And we think that's because PSP affects the brainstem structures that hold a role in emotional regulation. We also have the basal ganglia is heavily affected in PSP, and affects that frontal striatal pathway that can affect the control of emotion. And you've met many people with this condition, and you'll know what I mean by this emotional ability, that emotion can be expressed as disproportionate and inappropriate to the situation, and can be very distressing for the person and their family, but it's something that we do see quite a lot in PSP. So I want to kind of probably talk about core features of cognitive symptoms that probably you might think more frequently of when you think about these conditions. But there is an overlap between cortical basal syndrome, PSP, and some of the more frontal lobe syndromes that we see. I guess probably driven by kind of sometimes similar pathology and similar brain areas being affected. And this may be what patients find most distressing, which family and friends may find harder to kind of manage or to support people with. And it's really now thinking about kind of our executive functioning, and also maybe kind of thinking a bit about any behavioural changes that we also might see within these conditions. So I'm sort of now going to be grouping cortical basal syndrome and PSP together. So when we think about cognitive symptoms in these conditions, probably the one that comes to mind most is change in the domain of executive functioning, because it's such a dominant and prominent feature of someone's cognitive profile, and is very characteristic in what we would see when we carry out cognitive assessments with people. So what we mean by executive functioning is really think about, what would any good executive of a company need to be able to do? They have to be able to plan, organise, strategise, monitor what's happening. That's all what a good executive will be able to do in running a company, and that's the same idea for this executive function for the brain. It holds this kind of higher order role. And it's very common to see difficulties and changes here with both of these conditions. So you might see somebody having difficulties with planning, problem solving, implementing strategy. There can be a lot of rigidity to thinking. There may be some difficulty initiating action and or inhibiting that. We might see some perseveration. Somebody might get stuck. on doing the same thing or talking about the same thing. So it might be motor perseveration, you might see that in testing, and I can give some examples of that. We're thinking about the assessment process. Sometimes we can quite clearly see that in clinic, and by simple tasks, even like the pause test, which you might have heard of, where you might just get the person to clap you clap 3 times, you ask them to copy, and sometimes you take a perseveration of that kind of motor function. And there's quite a lot of nice papers again looking at the use of a pause test. A lot of the literature kind of evolved actually from the typical Parkinsonian syndromes, and it was thought to be a test quite sensitive to pick up cortical basal syndrome, PSP, but I think we're recognising it's just going to be a bit broader now. But it's quite a nice quick test to use in clinics. We might see a lot, significantly reduced verbal fluency in both of these conditions as well. And you might hear patients talking about kind of memory difficulties, and that might not be unusual. But I suppose it's thinking back to what type of memory difficulties might we expect to see here. And I guess that's why it's so important to hold in mind what we know about the condition, the brain areas it affects, and that kind of guides us for sort of what we might expect to see on cognitive testing. So when it comes to the memory difficulties that a lot of people might talk about, I suppose we're not expecting to see memory difficulties that would look like it would in an Alzheimer's, for example, because we're not seeing involvement in the medial temporal lobe structures that lay down new memories. What we might expect to see is memory difficulties more a kind of a result of the frontal lobe becoming involved, where frontal lobe kind of kicks in and initiates strategy to locate memories, the retrieval process. And what you might see in the test of a memory profile is it's not kind of true amnesic profile. It's much more around spontaneous pre-recall might be difficult, might struggle to come up with their own internal strategy to find previously learned information. But what we see is they do much better with prompts, with cues, so their recognition memory is much better. So we sort of will use a phrase, and we might say it's a frontally mediated memory difficulty rather than it being like a true medial temporal lobe memory difficulty. So that's kind of why I grouped that into the executive function slide here, just to kind of tease that out and help us understand a little bit more about why we might see that particular profile of memory. PSP and CBS are also conditions that we might also associate seeing a lot of kind of what we might call behavioural change, or family might say they're doing the same things they wouldn't normally do. Maybe they're essentially trying to describe a bit of behavioural personality change. And the reason why we maybe see this more in atypical Parkinson conditions than you might see in idiopathic Parkinson conditions is because of the breadth of involvement in the kind of frontal lobe and the breadth of involvement of those basal ganglia circuits affecting a broader area of the frontal lobe, basically. And it's affecting parts of the frontal lobe that we maybe associate more with what we call personality and behaviour. So within these conditions, you might see a lot of impulsivity and decision making. I think there's some thoughts maybe some of this will be worse in PSP than cortical basal syndrome. You might get kind of more lowered insight in PSP. You might see impulsivity being more of a dominant feature in PSP. That's because we're getting more involvement in our orbital frontal pathway. We might see a lot of apathy as well because we're getting involvement in the medial frontal pathway as well. We might see some reduced social cognition, kind of broader kind of behavioural change, like we spoke about, that kind of emotional ability, doing the same things you wouldn't do. I think it's harder to predict the involvement in the orbital frontal cortex from person to person. I think we don't always see it, and I think there's a reference I made earlier on. I think it's a Parmera paper from 2016 talks about the diagnostic conundrum sometimes of these conditions, and they can be quite variable. It's particularly cortical basal syndrome. There can be more variability in presentation, which can make it a bit difficult to know always what to expect or predict how things may change. Like I said, there's some thoughts that maybe some of these kind of more behavioural aspects might be more dominant in PSP. There's some thoughts that PSP may have a bigger impact in that orbital frontal pathway, and it has a more concentrated focus in the basal ganglia, and whereas CBS has more of a broader impact in some cortical structures as well. But this can be really distressing for friends and family to see these changes happen. So I wanted also just to talk a little bit about where mood might fit into this. So, and why it's important when we're thinking about cognition, why is it important to think about when we're thinking about cognitive assessment. So we know depression and anxiety can be a non-motor symptom of these conditions. We know apathy can be present as a distinct entity from depression. our neurology colleagues may already be treating some of these organic non-motor symptoms already. But we also know that mood difficulties can come around from adjustment to living with a progressive condition, and that can come around from grief over loss of health, loss of relationships, roles and opportunities from developing conditions like PSP and cortical basal syndrome. A lot of fear can be present for the future, what this may mean for them. Patients can hold a lot of fear about burdening others around them, and as their care needs perhaps progress and increase, because of a real loss of confidence in their abilities. And there can also be broader systemic factors within the family units and dynamics that can contribute to this as well. So because neuropsychologists are clinical psychologists, we're trained to assess mental health well. So we come at all these assessments and we think about cognition broadly, not just think about the role of the neurological condition, but we also think about the role mental health may also have in someone's cognitive functioning, because we know that mood can affect how we think. Low mood, anxiety can affect our attentional systems. That can then look like memory difficulties day to day, because if we're not attending to things that we need to do, it interferes with the rest of the processes for memory functioning. It may also have an impact on our ability to process things in a timely fashion. We also know motivation, engagement is lower with moods, so we maybe just aren't as engaged in things that are happening around us. It can affect effort as well. So when we're doing cognitive assessment, it may have an impact on how we engage in the testing that we're doing. So we need to know if that's relevant. We have to be able to account for this in our cognitive assessment. And because it can influence how somebody may do in the cognitive assessment, again, we may start to see things that aren't typical in the cognitive profile, and that's maybe when we think perhaps mood may be relevant here, and we may want to kind of think about treating or managing that first, and looking at that as a priority within our sessions. So I suppose in terms of if you have patients that you can see these cognitive symptoms in, which you will, if you think they can benefit from assessment, I guess thinking, well, what would that look like? When would you do it? Why is it helpful? And the assessment can be helpful for different reasons. So within my role, I suppose we do a lot of cognitive assessments that contribute to the diagnostic process. We can sometimes, even if someone comes with a known diagnosis, may want to complete some assessments to help the patient and the family understand the changes they're seeing. So information can go a really long way, and if we can help somebody make sense of what they're seeing, they can understand it, that can be really, really helpful. It then lets us kind of streamline advice we can give that person. And that's where mood also comes into it as well. So if we're trying to say, well, yes, there's cognitive symptoms here, second due to their condition, however, we're also concerned about mood. We think this is how it's having an additional impact on what we're seeing day to day, then we can come up with a much more tailored and personalised kind of treatment plan off the back of that. Neuropsychological assessments can also be really helpful. We're thinking about capacity assessments as well, as someone maybe moves through their disease progression and maybe have more complex decisions to make about their care. And sometimes we get referred people in fairly early on in their journey. They may not report many cognitive symptoms at that point in time, but actually what maybe is helpful for the team is to have a baseline cognitive assessment there that we can have to compare any future assessments to should concerns emerge over time, or if more kind of clinical questions emerge that are relevant to cognition. So there's a variety of reasons, I suppose, to hold in mind as to why you might ask for cognitive assessment. It may be that within your clinics or your roles that you hold that it's possible to do some screening in the first instance, and that will just depend on the roles you hold, training, confidence to do so maybe. There's a lot of screens that we might kind of put our hands to. There's a frontal assessment battery can be helpful because we know there's a really dominant kind of executive profile here. Ads and books can be used by people sometimes, but there's also quite a wee bit of literature looking at the MOCA, and it's used in Parkinsonian conditions. So sometimes that could be the more common one we tend to use. But there is a training aspect to this, so it gets us just making sure that you meet the minimal training criteria to be able to administer the MOCA, and that's available to check online so you can see for yourself if that's something you can do. Quite often our clinical and our specialists may do some screens if they've got concerns and want more detailed assessment. That's when they refer on to the neuropsychology service, and that's where we would become involved at that point. It's important to hold in mind cognitive symptoms, important to hold in mind assessment, because it has a significant impact on people's lives day to day. It can affect them managing affairs and finances, independence, planning for the future, making decisions, learning new tasks. It can affect relationships, and like I said, information and understanding what we're seeing can go a long way to kind of mitigate some of those challenges. If you are seeing cognitive symptoms, or we, within your own clinics, or if I see patients and assess cognitive symptoms and we want to kind of look at different management strategies, there's a variety of different things that we would think about. This isn't an exhaustive list by no means, so it might be helpful if there's anything else people would add to this or want to share today, because this is by no means everything. But I suppose we want to kind of think about maybe environmental changes, minimising demands and distractions, making tasks a bit more simple, using visual aids if we're noticing kind of quite a language difficulties coming through. We might want to kind of make them independent with managing things day to day, supporting memory. We know that they are able to encode, consolidate, and store memories. It's the retrieval that's difficult, so we might all think about strategies we can put in place for reminders, using smartphones, Alexa for reminders, things like that. I've done a lot of work with patients to get impulsivity, and we sort of use a traffic light or stop system with that, which can be really helpful. Not everyone wants to get on board with that. I suppose it's a bit of a personal choice, but patients who are very engaged with it and family who are very engaged with it, it's a very, very simple strategies, and we've seen, quite a lot of positive changes as a result of that. We maybe encourage family to kind of break tasks down to fewer steps, simplify language where possible. Education goes a really long way. We can't reverse cognitive symptoms. There's not a cure for them. It's part of the condition that we see. But understanding what they are and family making sense of them can be really helpful, and get them on board with the management of this. Put blending affect here, and what I mean by this is sometimes patients and families might struggle a little bit with the kind of emotional ability side of things, and it can become very embarrassing for people. It can make them not want to go out, go places. So sometimes in the past we've come up with strategies, if they become, if laughter is one of the things in our cafe in their own, we might say, well, how do we blend it into more natural behaviour? So for example, they would just pick their phone up as if they're sort of laughing, or to someone that's on the phone to them. We'll come up with different strategies they feel a bit more comfortable, just to kind of blend it into more natural movement, or more kind of what they might feel is more socially acceptable. And we never ever underestimate the good foundations to promoting general well-being, good diet, exercise where possible, looking after sleep and assessing sleep. If you need to signpost onwards, I know local services can vary. You might not always have access in your psychology service. But if you do, it can be really helpful to determine how we can best support people. Within your clinics, we've used, here in Glasgow near Shrinari, we've used the distress thermometer, and that's a kind of nice way for our HPs and neurology colleagues to perhaps work out what's causing that patient the most distress, and then filter referrals onto the right services to support their needs, because not everybody who's distressed has to come and see a psychologist. There could be other services that can be helpful. We link in a lot into speech and language and OT therapists. We'd be lost without them. So we very much use their expertise a lot, and we would encourage you to do the same. I think working in the jobs that we do, I think it's everyone's responsibility to offer psychologically informed care, to ask about mood, to ask about cognition, to be okay asking about well-being, and just, I guess, know where you can refer on if you need to. In terms of mental health, some people do come to your psychology. We would see them for intervention, but sometimes people don't need that. They just need a bit of support. They can maybe work through on their own. There's some Silver Cloud online modules you can access, but there is referral into mental health teams or neuropsychology services if that's available. But I think ultimately, I guess the kind of take-home message is that it takes a team to offer good care for our patients and their family. Cognition is really important to hold in mind, but we're not expecting everybody needs that. And if you need any further advice and guidance on it, then I guess having a think about what's available to you to link into psychological services to support you as a team. And I think that's it. Sorry, whirlwind.
Fantastic. Thank you, Susan. Great, a great talk. We've got a number of questions for you, if that's okay. So I'm going to start with a question from Michelle. And the question there is, a patient loses some speech and word processing, and then it regains again a couple of weeks later. What happens for this to occur? Ooh. And I think this was a PSP situation. And I mentioned this on the chat, and when it does come back, it's not quite as good as it was before. I think that was a subtext on the chat.
Well, that's a good question. I don't think I immediately know the answer to that one. That's a wee bit unusual. So they lose speech and word process and regain it, and it's not as good.
Yeah.
So So something a wee bit more transient there. And I don't know. I think I need to ask a lot more questions, maybe to kind of get a wee sense of what that might be, what I'd be considering. So I guess I'd be kind of thinking of, I'd link in with my neurology colleagues first and foremost to say, what do you think this might be? Because I think I'd be lying if I said I had the obvious answer. I suppose if certain things are transient and affect speech, I'd be wanting to make sure there's nothing else neurologically going on as well. I guess I'd be kind of speaking to speech and language therapy colleagues, maybe make sense of that. I'd be also kind of thinking about things, is anything else maybe from like an apathy point of view or mood-related factors that may make someone disengage, withdraw, and with natural fluctuations we can see in that. Is that when we're seeing them kind of re-engaging back? I don't know. I suppose it's just a couple of thoughts I would have. I think it would very interesting, very interesting. As I can see Michelle on the screen nodding, so I've just worked out where Michelle is. And I can see her thumbs up agreeing that was one that kind of confused probably a lot of people. As well.
I guess, Michelle, we will put it out to a wider panel as well, because we are going to make sure that every question gets a response, and we've captured your response, of course, anyway, Susan. So.
But I suppose I guess I would be just trying to rule out any other reason why you had that transient dip or change, and that could be quite broad as to what that might be. For general health, is there anything else at play from a medical point of view that I guess like things like UTIs and things, for example, can cause a bit of confusion, some other difficulties that might be transient once treated or resolved. So yes, I suppose at this point, I guess it could be quite broad, and I don't know one specific answer, but I'd actually be curious to know myself if anyone did have that answer. So yeah, if I could be included in that, that'd be helpful.
Well, we will definitely attempt to get other perspectives on that. The next one we've got is from Vicky Allenson, and I love this question because it reminded me of some of the cool stuff that we're doing with eye tests. And so it says, we've had a few new patients over the past few years that were referred to speech therapy due to a newly acquired stammer, and they presented very much as a stammer, but they've gone on to neurology and received no diagnosis. But their symptoms have deteriorated, and eventually they've received the diagnosis of PSP. So what they're saying, is this in particular is an early sign, or is it a coincidence?
I don't know what other people think on today's meeting, but I think PSP can be a kind of funny one where sometimes it can present with quite initially sort of odd or symptoms that we're not quite sure how to make sense of. And sometimes if you watch those patients, you realise actually PSP is what kind of emerges over time. I think it would probably depend on what investigations or assessments the neurologist did. But I suppose kind of thinking about, we know language can be a feature of these conditions. We know that we've got those kind of big loops that come off the basal ganglia projecting to the frontal lobe. They have an impact on kind of maybe the motor aspects of speech. It could be a very early sign, but I suppose the neurologist maybe on examination wasn't picking up anything, suggest kind of Parkinsonian symptoms at that point in time. Perhaps there was no other rationale. Well, I mean, I suppose with new onset stammer, I don't think any neurologists on the call, but I wonder with new onset stammer language difficulties if it would be protocol to do imaging at that point in time to see if there's any structural cause for that to happen. So I suppose I wonder if that did happen at the time and you weren't seeing any typical changes on MRI, there was no kind of midbrain atrophy, nothing that was suggestive of PSP. Perhaps at that point in time they felt there wasn't enough evidence for them to confidently make that diagnosis. And sometimes I think with these conditions, sometimes it can unfortunately be a wee bit of a watch and wait, and things transpire in time as the kind of constellation of symptoms become a wee bit clearer, that will allow us to then start to develop a bit more of a hypothesis around what we think it might be.
Okay. Thank you. And again, I think that's a great question. We can go out to a broader panel as well. Dawn Swatton has asked the question, do you recommend early cognitive assessment to provide a baseline and help and educate people and their families, or would you provide support as symptoms arise? That's quite interesting because in your presentation, you kind of talked about signposting and that sort of thing, but I guess over to you.
So I sort of do both. You know, I definitely maybe people might have different schools of thought on this. But within the service I work in, an atypical movement disorder team, I do get usually patients might get referred to me where there's maybe just some subtle cognitive symptoms, so it just might be mentioned in consultation with the neurologist. But we have a kind of broader conversation with the family. It's maybe symptoms that aren't causing particular impact day to day. It's not really to a level where it's causing significant difficulties, but it can be helpful, I think, to have a baseline to compare to. And if that's something if someone's happy to do and willing to come back for, we'll complete that. I think it's helpful to have that comparison further down the line. So I think depending on your service, I can't say that every neuropsychological service will have the same stance. I think assessment early on can be helpful for a baseline. I think offering early education around cognitive symptoms and the condition can be really helpful to prepare the patient and family to make sense of what they're seeing. And we will always see patients back if cognitive symptoms progress and worsen. And I think if we've got a comparison, it kind of puts us in a stronger position as well, particularly when we're talking about rate of decline in cognitive symptoms, if we're starting to kind of raise conversations about power of attorney being put in place. If there's any questions about incapacity, we are in a position to say, well, actually, yes, we're seeing a rapid decline from a completed baseline. This is directly secondary to their neurological condition. Or if they come back and repeat the cognitive assessment, we're not seeing a huge difference in scores, but actually we think, well, what else is going on for that person and what else is happening? That's when your broader assessment comes in. So I would say there is value in it.
Okay. Thank you. A last question, Susan. We're working you hard here. This is from Helen MC. Other than SSRs, are there any meds that can help with the aggression, personality changes, and impulsivity?
So that, because I'm not medically trained, I don't prescribe medication, and that would really sit with the neurologist or a geriatrician or the nurse specialist to give advice on. So I'm sorry, I don't feel I can answer that one specifically, just because it's slightly out my lane, I think.
Okay, all right, thank you. I've just been seeing on the chat, it's wonderful when you get a chat that's really alive and somebody's responded to a previous chat and so on, and so really great. Thank you once again, Susan, for your presentation. Just a reminder for everybody, that whole recording and materials will be made available shortly. We are going to switch gears now, and I'm just going to be sure. I think it's I think it was you, Dominic. I saw you come there with the big red and purple screen behind you, so I assumed it was you next. Once again, thank you, Susan. We are going to hear from Dominic, and then we will be taking our lunch break after that. Dominic, are you ready?
Hi, Paul. Yes, I'm ready.
All right. Well,
my screen.
If you share the screen, and then I'll get off on mute rather, and then there'll be no background, and then the floor is yours.
Right. Can you see my first slide there?
I can confirm I am seeing your slide, so I'll get out of the way and let the magic happen.
Awesome. So hi everyone. So my name is Dominic Burdon. I'm a Neuro-Orthoptist and I work in Plymouth. So in Plymouth, we run the Plymouth Ocular Motility Unit, and I run this with Professor Harris. And together we test sort of complex eye movement conditions, which PSP fits into for us. And today I'm going to be talking about the ocular signs of PSP, and how you test for these ocular signs, and also going to be talking a little bit about the neurology behind these different eye movement systems. So I do apologize for quite a wordy first slide, but I thought this was a really good table, which basically breaks it down quite nicely in terms of the ocular signs, and also talking about all the different predominance types for PSP. So as you can see here on the left-hand side, there's the kind of diagnostic certainty for a diagnosis of PSP. And naturally, as you kind of get higher up the certainty level, you tend to find that you get more ocular signs. So here you have kind of O1, which is a vertical supranuclear gaze palsy. O2 is a slow velocity vertical saccade, and then further down, providing less kind of diagnostic certainty, is O3, which is macro square wave jerks and lid abnormalities. So moving on to what the different eye movement signs actually tell us with regard to the certainty. So a vertical supranuclear gaze palsy, I'm going to talk about how to diagnose that a little bit more later. But that actually has a really high sensitivity and high specificity when diagnosing possible PSP. So that's kind of right at the high level of certainty. Further down, you have the vertical saccade abnormalities, and then further down, again, you have the square wave jerks and the lid abnormalities. In terms of how these ocular signs tell us what stage of disease the patient is at with regard to PSP, it's quite nice to break the ocular signs down into 3 groups. So you have the lid abnormalities, and these are broken down into decreased blink rate, blepharospasm, and then lid opening apraxia. Generally, they get kind of decreased blink rate initially and blepharospasm initially, and then kind of later on in the disease, they'll have lid opening apraxia. With regard to the eye movement abnormalities, it's really, really good to test these different eye movement abnormalities, because it can really tell you what stage the patient is at with regard to PSP. And certainly kind of slow velocity saccades, vertical saccades, is a good indicator that they're quite early stage. As the eye movement control degenerates, they develop into having a vertical supranuclear gaze palsy, and then later on in the disease, they'll have complete ophthalmoplegia, which means that these patients kind of are stuck looking in primary position, and they have no voluntary eye movements side to side or up and down. In terms of fixation, I generally say that this is not as important to look for, because it can be quite hard to assess really looking for square wave jerks, which are really small kind of saccadic intrusions, very small kind of eye movements horizontally. And also, it doesn't really give us any information on kind of what stage the patient is at with regard to the disease progression, as they tend to stay quite stable throughout the disease. So I wanted to talk about the ocular symptoms. So the research shows that a lot of patients with PSP do get diplopia, which is double vision. Also, they get light sensitivity, so kind of 61% for double vision, 43% for light sensitivity. But actually, what we find is that they might not always report these symptoms or experience them. So I just wanted to highlight really that even if a patient is not complaining of symptoms of eye problems, but if they have other signs generally of PSP, it's really important to still test these ocular signs. Also, these patients will complain of difficulty reading, and quite often when you ask them kind of why they have difficulty reading, they're not really sure why. And this is quite often because they get a symptom called confusion. And this is where if their eyes are not quite aligned because they're not able to move their eyes properly, they will basically be looking at one thing with one eye. And if their eye is out of alignment, they'll be looking at something else with the other eye, but perceiving it kind of overlapping each other. And this can cause what we call confusion and make it very difficult to read, but the patient will kind of not know exactly why. In terms of management for the double vision, we can offer prisms to join the the two images. We can also, if needs be, we can offer some occlusion, which might be frosting or a patch or an occlusive contact lens just to help them kind of manage those symptoms of double vision, which can be quite debilitating. With regards to the photophobia or the light sensitivity, we advise on kind of strategies around this, kind of reducing light levels within the home, use of tinted lenses, and also it's really important with regard to kind of light sensitivity to ensure that the patient's eyes are well lubricated with eye drops. So I wanted to talk a little bit about what supranuclear means. I know Boyd has kind of touched on this as well. I felt like seeing as it's in the name, it would be a good thing to kind of break down. So supranuclear, basically, this diagram breaks it down quite nicely, actually. So we have the eye here. We have the extraocular muscles around the eye. So these are the muscles that are used to pull the eyes in the different directions, up, down, side to side. Here we have the infranuclear pathway, which goes to the nerve nucleus. And then from the nucleus, we have these supranuclear eye movement pathways, which go to these eye movement control centers. And what these supranuclear pathways control are the different eye movement systems, or the different eye movements. So with PSP, this is really important, because the way we diagnose supranuclear vertical gaze palsy is by looking at whether the patient has some supranuclear neural pathways intact and others which are dysfunctional. And with PSP, we find that initially the saccades will be dysfunctional, but then as it progresses into a vertical supranuclear gaze palsy, their eye position will be dysfunctional. And then finally, as it kind of progresses to complete ophthalmoplegia, also the vestibulo-ocular reflex will be abnormal as well. So at that stage, it's become it's progressed and become completely nuclear. In terms of the smooth tracking, which is an eye movement system where we're just required to track things in our visual space as it moves across. The control center for this is in the cerebellum, and it's actually quite often preserved in PSP. So where are these control centers in the brain? So with regard to the saccade control center, which is the rostral interstitial medial longitudinal fasciculus, with a mouthful, it's right up here in the midbrain. And with regard to the eye position for vertical eye movements, it's in the interstitial nucleus of Gahal, which again is quite high up in the midbrain, close to the third nerve nucleus here. And with PSP, vertical eye movements are abnormal initially because naturally the PSP or the tauopathy affects them high up in the midbrain, and it gradually, as the disease progresses, it moves inferiorly into the pons. And down here we have the control center for horizontal eye movements. So yeah, here we have a rule really, which just kind of breaks it down quite simply. If there's a vertical eye movement problem, the problem is in the midbrain. If there's a horizontal eye movement problem, it's in the pons. And also right down here, we have the vestibular nuclei. So as I said previously, testing the vestibular system is usually preserved until quite late stage with PSP. And the reason for that is because it's quite low down in the pons. So as it progresses, it degenerates quite late on in the disease. And one final point I wanted to make is that up here in the midbrain are the connections from the right eye to the left eye. So we quite often find with progressive supranuclear palsy that the eye movement signs degenerate or are dysfunctional quite symmetrically in both eyes, and that's because the connections between the two eyes neurologically are quite high up in the midbrain. Okay, so just starting off with a saccade and how you test for this is actually really easy. All you have to do is hold up two objects in front of the patient, and it's usually kind of 20 degrees apart or more. You get the patient to look between the two objects horizontally and vertically, and all you do is you observe them as they do that. You assess their velocity. Now, these movements in a typical patient will be very fast, swift movements from point A to point B. In patients with PSP, we find that the vertical is affected initially, and also we find that they have quite low velocity initially. As the disease progresses, it will become hypometric, which basically means that rather than going from point A to point B, it will kind of go to a point before point B and be quite jerky and juddery. And that's what we call hypometria. Hypometria of kind of 10% or less is quite normal, actually, but multiple hypometria is abnormal. So that's with regard to accuracy. We can also look at the conjugacy, so look at whether both eyes are moving in tandem with one another. And also, we can look at the round the houses sign, which is quite characteristic in PSP, which is a sign where you get them to do a saccade from point A to point B. They will not go directly in a straight line. They will do an oblique saccade kind of around the houses. And that's kind of demonstrated in this picture here. Wouldn't be straight from point A to point B, it does an oblique trajectory. So the origin for saccades is in the RI-MLF, or vertical anyway, and it's burst pulse neurons that are required to move the eyes. And sort of late stage with regard to saccades, you find that actually as it progresses, it might be slow initially, and then it might be quite kind of difficult and hypermetric, and then late stage, unfortunately, they kind of develop into not being able to initiate a saccade at all. So here we have a video, and this is a patient who is doing a horizontal saccade. You can see here that they're pretty good horizontally. And then just for comparison, this is on the same day, the patient being asked to look at targets kind of vertically now. So he can look up okay, but he's really struggling to look at point B in depression. You can see right at the end there, he makes one downward saccade, but he's being asked to look up, down, and really struggling to move his eyes down there. So in this case, this is really characteristic of PSP, the difference between the horizontal and the vertical ability with the saccades. Okay, moving on to eye position. So we test eye position or ocular motility by, again, it's quite a quick, easy test. Get the patient to keep their head nice and still, and some people call it blessing the eye movements, where you hold a light or something as a target. You get them to look up and down into the different positions horizontally. And as you do this, you can record. As you do this, you can record their range of movement. So you generally find that the vertical eye movements are affected first, or their eye position is affected. And one thing to note with kind of assessing elderly patients is that due to the physiological changes of the eye muscles, a small upgaze palsy or difficulty with moving your eyes up is not uncommon, actually. So kind of a -1 restriction in elevation is not uncommon. It's not a kind of characteristic of a pathological eye movement problem. Whereas any restrictions greater than -1 is something that is abnormal. So in this case here, you can see that the patient is not able to elevate their eyes at all. There's a -4 restriction in elevation, both right and left. And also there's a small restriction in depression as well, which is very uncommon in elderly patients. The reason why the physiological changes happen with the muscles is that the muscles actually get displaced inferiorly, so that will actually help with depression. So any kind of restrictions of depression is a red flag. Now, the control center for vertical eye position is, as I said previously, it's high up in the midbrain. It's the interstitial nucleus of Cajal. For horizontal, it's the nucleus brachiocetus hypoglossi, and that's further down in the pons. So again, just kind of showing how vertical eye movements are affected before the horizontal. So here's a video of a patient who has complete ophthalmoplegia, but he does have his vestibular-ocular reflex preserved. You can see here that we're kind of asking the patient to follow the light horizontally. Just again, and he's not able to look towards the light or follow the light at all. This same patient, assessing his eye position vertically, again, he's not able to move his eyes voluntarily vertically. Okay, so moving on to the vestibular-ocular reflex, which is another supranuclear eye movement. And this is in the medial vestibular nuclei, low down in the pons, which is why it's kind of affected later on in the disease. And you test this by what we call a doll's head maneuver. So now, instead of looking at the voluntary eye movements, we're looking at the involuntary reflexive eye movements. And we do this by, instead of getting the patient to hold their head still and move their eyes, we get the patient to hold their eyes still on something and move their head. So we can do it horizontally, we can do it vertically, and we assess their eye movement range. One thing to note with this test is it can be quite difficult with patients with PSP due to the muscle stiffness and the nuchal rigidity. That can make it quite difficult to kind of do the doll's head maneuver vertically, especially. But here I've got a video of this same patient as before. He voluntarily was not able to move his eyes at all, but you can see here when testing his doll's head maneuver, he's able to move the eyes in all the different positions horizontally and vertically as well. So this is how we know this patient has a vertical supranuclear gaze palsy. Goes out of view a little bit for the up gaze, unfortunately, but I think you can see it there. So I've created a bit of a kind of pathway for diagnosing supranuclear gaze palsy. So first, test eye position. Are there any vertical gaze restrictions? If so, you then test the VOR. If there's increased range on the doll's head maneuver, you know it's supranuclear. If you test eye position and see a vertical gaze restriction, but there's no improvement on the vestibular-ocular reflex test, you then know that it's nuclear gaze palsy. It might be that you're actually assessing the patient quite late in the disease, or it might be that they've got something else going on. And finally, if you don't see any gaze restrictions on eye position assessment, we then need to move on and test for other ocular signs of PSP, like the saccades, which will present early on in the disease. So moving on to lid signs for PSP. The lid control center is kind of in the upper brainstem. We're not entirely sure specifically where in the brainstem. And we find that the lid signs with PSP are quite characteristic of the condition. There's not many other conditions which present with these characteristic eye signs or lid signs, and they'll have a decreased blink rate. Naturally, we say a full blink is eyelid closure of greater than 50%. A typical blink rate with kind of typical patients is 12 to 15 per minute, whereas research shows that with PSP patients, it's about 2 per minute, quite a significant reduction there. And this can cause problems with dry eye, corneal problems, and can lead to the symptoms of kind of photophobia and light sensitivity. So it's really important that kind of eye lubrications are provided. Blepharospasm is another symptom, which is where the eye muscles or the eyelid muscles will kind of spontaneously contract, and this will look like almost a bit of a spasming of the eyelids. Research has shown that there's good success with treatment for Botox injections into the eyelid muscles for this. So this is something that can be treated. Later on in the disease, we tend to see lid opening apraxia, and this is really easy to test for. Basically, you ask the patient to close their eyes and then open them, and naturally, if the patient has lid opening apraxia, you will see quite a significant delay in them opening their eyes. So I've got a video here of a case who has who's got blepharospasm and lid opening apraxia. You see here that we've asked the patient to close their eyes and open them, and he's really struggling to open his eyes. He's raising his eyebrows and tensing his frontalis muscles to try and kind of force the eyelids open. Just play it again. He also has some blepharospasms, so you can see here that as he's trying to open his eyes, they're kind of spasming a little bit. You see it here, some spasming. He has blepharospasm as well. Another thing I just wanted to point out with kind of lid signs is that patients, because of their decreased blink rate and their quite stiff facial muscles, they tend to have quite a characteristic expression, and they'll be staring a lot. You might see that due to their lid problems that they have quite a lot of kind of forehead wrinkles because of their frontalis overaction, trying to like kind of raise the eyebrows, and they generally have this kind of expression of astonishment. Okay, moving on to fixation, which is that kind of third group of eye movement problems, which involves square-waved jerks. Now, we're not entirely sure why this is affected in PSP, because the issue tends to, well, we're not sure why it's affected early on in PSP, because the pathophysiology for this is quite low down in the pons, or sometimes it's cerebella. And a square-wave jerk basically is where, in an ideal world, a patient will look at what they want to look at. If the patient has square-wave jerks, unfortunately, as the patient looks at what they are looking at, a very quick burst eye movement away from the desired location will happen, and it will stay there for a bit, and then it will come back to the desired location. So it's these constant kind of eye movements away from the desired location. And it's quite normal actually for patients as they get older to have some square wave jerks, but they're naturally quite small, less than 1 degree. With patients who have PSP, we find that they're a lot larger. We call them macro square wave jerks, so sort of 3 to 4 degrees, and also they're a lot more frequent. So you see here that if you have a younger control group, a couple of, just to talk about what this diagram is showing. This is an eye movement waveform, and an upward movement is to the right, so a rightward movement. downward waveform is to the left, and then across the x-axis is time. So you see here with the younger control group, there are a couple of little movements away from the desired location. As you get older, these kind of square waved eye movement jerks are a little bit more frequent, but still quite small. And then in the PSP group, you can see that they're a lot more frequent and quite large as well. So this also might cause symptoms of kind of difficulty with reading or difficulty seeing. Now, picking up these jerks in free space, just observing the patient, is actually quite difficult. So having an eye tracker is really helpful, so you can assess the waveform like this. The final eye movement issue that patients with PSP tend to have, that I wanted to talk about, is vergence. And vergence is the ability to converge your eyes and maintain both eyes looking at the desired object as it's brought closer. And the pathophysiology for this is generally in the upper brainstem. We're not sure exactly where. They'll get symptoms of double vision or difficulty reading if there is a vergence abnormality. And that's because if they're not able to converge both eyes on the page, then they might get the double vision. That's because one eye is dominant, and they'll see the image with the dominant eye, but also where the other eye is looking. So the double vision will be kind of next to each other. They also might get confusion, which is where they are looking at kind of both images, but kind of one over the other, which can be quite disorientating. We can treat this with prisms or occlusion to help with this. As a general rule, we say that converging past within 10 centimeters of your eyes is considered kind of normal, but if the convergence is anything kind of further away than 10 centimeters, it's abnormal. And then we do find with patients with PSP, eventually it does progress, and they'll basically have no vergence by the end. So that will mean that if you're looking at the patient, you present them a target, and as you bring it closer, their eyes do not move at all. One point I wanted to make with this is it's really important to differentiate this from convergence, just pure convergence insufficiency, because that's just a purely muscular thing. We can give you some exercises to help with that. Now, if you do see this in clinics and convergence insufficiency, and there's other signs of PSP, then it's really important to do all the tests to look for the cardinal signs for PSP as well. I wanted to add in a slide on eye tracking as well. It's not something that's kind of readily available, but we find it's so helpful for us testing the eye movements in PSP, especially for picking up those really early signs of kind of vertical saccade low velocity, which can quite often be quite hard to pick up in just observing the patient in free space. So we do find an eye tracker really useful for picking up kind of early eye movement signs of PSP. And it's really good because it breaks the waveform of the eye movement down into right and left eye, horizontal and vertical, and you can kind of adjust the settings so you can really zoom in and get a good view of how they're using their eyes. In terms of kind of eye movement signs in other Parkinsonian disorders, we generally find that the eye movement signs are quite spared with the conditions like CBD, Lewy body dementia. MSA is slightly different because of the cerebellar type of MSA, and cerebellar problems can cause eye movement problems. Not typical of PSP, but they do have eye movement problems like saccadic pursuit, which is where following can be difficult. They might also have something called gaze-evoked nystagmus, which is where when they look to the side, they'll have a bit of a wobble, and they might also get square wave jerks. Okay, thank you for listening. I'm more than happy to take any questions now, or I can be contacted at a later date if you want any more information on kind of how to do these tests in clinic. As I said, I can't stress enough that actually they're quite easy to do and quite quick to do in clinic. All you need to do really is just record what you see, really, and afterwards, once you've done the tests, write down your results and see if that kind of picture coincides with maybe a PSP picture. But yeah, more than happy to be contacted. We're also more than happy to accept any referrals if you feel like our assessment would be useful for a patient. Thanks for listening.
Thank you, Dominic. That was an outstanding presentation. Really, really clear in terms of the various things to look out for. And it feels like that there's a clear pathway, and each one of those, whether it's blinking saccades or the fixation, that they just add and add and add to pointing you in that direction. So thank you, that was really, really clear. You don't get off the hook that easily. There are some questions that you could possibly imagine that have come in on the chat, so we're going to share those if that's okay. We're doing okay for time. So as we've got you and all that great experience for yours, we're going to ask you to respond to a few questions. I think we may have a few more coming in as well as we've gone on, but the one so far, this one's from BG Joseph. Is nystagmus or jerky eye movement more related to PD, which I'm guessing is Parkinson's disease, or PSP?
So nystagmus is it's not generally a sign that we see too much with PSP, and also you don't tend to see it too much with PD either. It's not a characteristic sign of PD. So if there is a nystagmus, whether that be gaze-evoked nystagmus or other type of acquired nystagmus, I would kind of consider whether there's something else going on, to be honest. With Parkinson's disease, we do find that they'll have square wave jerks, which is slightly different. That's so a nystagmus movement is where they struggle to hold their fixation in a certain direction, and because of that, the eyes drift off from that desired location, and then they do a refixation movement back to the desired location. And this is a constant movement, so you see a quick phase and a slow phase. So it's kind of a jerk like that. Whereas square wave jerks or saccade problems is more of a very swift movement from one position to the other involuntarily. And we tend to find more saccadic intrusions with PD or PSP, certainly more so with PSP. But yeah, I think to summarize, with nystagmus, we wouldn't usually expect that with PSP or PD. So if there is signs of that, you'd probably be thinking, is there something else going on?
Okay, thank you. The next one is from Michelle. How do prism glasses help, and how are they accessed?
Yeah, so prism glasses can help in different ways. There's you can prescribe some glasses which have what we call peliprisms, which basically stops the need for having an abnormal head posture. Also, prisms can be used to join double vision. So if there's kind of two images next to each other, which patients with PSP quite often get for reading, we can provide some prisms which basically just join the two images back together, allow the patient to kind of see binocularly again. And also we find that if there's a patient who is struggling to look down, which is really debilitating for patients because you need to look down to walk around. It has been kind of hypothesized that it's that causes the postural instability and the falling. And also kind of eating, reading, a lot of your daily tasks actually is looking downwards. So to help with this, we do kind of prescribe some quite thick glasses, which can just basically mean that the patient doesn't have to actually move their eyes to look down. They can look straight ahead through the prism, but then the prism refracts the light so that they are looking downwards. Quite hard to use, to be honest, but we can prescribe it. I think also with regard to kind of difficulties with looking in different directions, the main thing really is just explaining how that will be a problem for the patient and how to get around those problems. So compensatory strategies is really important. With regard to prescribing prisms, your best bet really is to get a referral through your GP or your optician, and get a referral to the orthoptic department. Orthoptists are the experts when it comes to prescribing prisms. We can prescribe kind of temporary prisms on glasses, just to trial for a period, and then if they work, we can then incorporate it.
And just to build on that, Dominic, I know Carol's just put in the chat there that actually the PSPA, if we call the helpline, we can help with prism glasses as well. So, okay,
oh, great.
So there's a few more. So this one's from Amanda Reed, which says, who performs Botox in breathospasm? Hopefully I said that correctly.
Yeah, really good question. So that is I'm not sure if it's different in different eye departments, but we have an oculoplastic ophthalmologist within the eye department who can do that. So it would be a referral to the appropriate ophthalmologist at the eye department. We've got a specialist in that field who is very happy to accept referrals to consider that. Yeah, but it would be an ophthalmologist at
So there are orthoptists doing it now as well. They do it in Manchester and they do it at Moorfields.
Oh, great. Great.
Excellent.
Some others, obviously, but it depends.
Yeah, that's what I mean. It can vary quite a lot between eye departments, kind of what roles people have.
Okay, thank you for that. I got a bit of a break up there, but please do add that stuff onto the chat, because the great thing about the chat on Zoom, if you don't know that we can capture all of it in text and share some of this good kind of signposting and guidance is really, really good. So there was another question, which was around, do you know if Neuro-Orthoptics is generally available across the country? That was from Amy Scott.
Yeah, so I think the level of care probably varies, actually. There's one thing that we are trying to kind of correct really here in Plymouth. We're really keen to kind of raise awareness of how to pick up these signs, these ocular signs for PSP. And we're kind of targeting orthoptists just to make sure that when a patient comes in with general signs for PSP, or maybe these other signs which, like maybe double vision for near, which can sometimes be kind of diagnosed as something else, really important to look for these other signs, like lid signs or vertical supranuclear gaze palsy, saccades, things like that. So we're trying to kind of raise as much awareness as possible, really, to make sure that it's not a postcode lottery with regard to kind of
in Compton 500 9651. So if you
could somebody check their mute button? We've got an open mic.
Yeah, most eye departments should have orthoptists that are well trained in assessing eye movements for kind of neurological adult patients.
And I guess related to that, another question that came in from Caroline Bartliff, which is, do all ophthalmologists know about PSP and feedback to the neurologists if there are atypical eye signs?
Yeah, again, I'm not too sure. I think that's one thing that is a really important thing to raise, and I think it's really important to raise as much kind of awareness of PSP, because it can go undiagnosed, but we find that these patients have such debilitating eye signs and eye conditions, which they don't always report. So I think in our department, our ophthalmologists are very aware of it, because we accept a lot of referrals from neurology, and we have our kind of eye movement assessment procedure that we do with these query PSP patients. So we've ensured that kind of the whole eye team are very aware of that. But I'm not too sure kind of what the level of awareness is at all eye departments, and for these ocular signs of PSP, which again is something that we really keen to ensure kind of happens, as much awareness as possible, just to ensure that kind of they get all the eye care that they need, and this kind of interprofessional working is kind of facilitated as much as possible between different teams within the hospital.
And so I'm just that's kind of what you've just done here, actually, is helping raise awareness in such a way that's really easy to consume if it's kind of new to this, or even familiar to it. So I mean, this presentation I think will be incredibly valuable anyway, for the association to again share and raise awareness. I actually had a question. And I thought, well, is it cheeky? Given we're all right for time, I'm going to ask the question that I've got, which I think you've kind of answered, but I'm going to ask it in a different way, which is, are there any other conditions, medical conditions, that have the combination of factors that you've explained? So when you went through like the saccades, the blinking, fixation, and the vergence, is there any other condition that would be expressed in all of those, in a whole combination? Or is that such a very strong diagnosis or diagnostic? So,
to be honest, not really. No, it's a very, very strong. Certainly, if a patient has all of those signs, we would be very kind of very sure that the patient would have a PSP picture. So yeah, it's the research that's been done in this area actually shows that just the vertical subclavian gaze palsy is quite kind of good as a very sensitive and specific sign for picking up PSP. But certainly if they have that plus the lid signs, plus the macro square wave jerks and the vergence problems, we'd be kind of 99% sure that there would be kind of a PSP picture, to be honest, because there's not really much of a differential diagnosis with regard to those signs. Yeah, there's not really any other conditions that would just purely present with that.
Okay, thank you. One last question, and then we will break for lunch, which is, this comes from Helen Rayner. Do you have any strategies for helping with reading?
Reading is, really challenging for the patient. I think it depends on why they're finding it difficult with reading. And as I said in my talk, quite often when you ask them why, they're not really sure why. But if you dig in a little bit more, you can usually kind of find out whether it's blurred vision, in which case they would need an updated pair of glasses, or maybe when it comes to blurred vision, certainly single vision glasses are essential, because with varifocals it requires eye movements to be able to see through the correct lens, and if the patient has a difficulty looking down, they're not going to be able to look through the right part of the lens to be able to read. So single vision glasses is a must really with patients who have vertical gaze problems. With regard to double vision, we can offer prisms, but we do find that because of the progressive nature of PSP, that prisms we can give it to them, but then a few months down the line they're not really working. So then we need to kind of either change the prisms, or we quite often find that actually occlusion is the best solution with reading, just because it completely eradicates the problem of the second image, and it also eradicates the symptoms of confusion as well, which is where kind of two images are kind of superimposed, which can be quite disorientating. And then the final thing really is just compensatory strategy. So maybe increasing the text size, ensuring that you place what they're trying to read in a quite high up, or a place where they can actually move their eyes. Things like that can really help.
Okay, thank you, Dominic. We made you work for your lunch. Excellent presentation again. If there are other questions that came through on the chat towards the end there, we will get them answered and get them come back to you. So just as before we stop for lunch, I'm just going to remind people what is coming up after lunch. We're going to be starting again at 2 o'clock with physiotherapy from Jade Donnelly that works with Boyd. I've got to do a bit, I think, but I'll share you that at 2:45. And then Annalise finally, which is really great stuff from the research symposium. So great morning, a whole range of topics, which I think will be absolutely fabulous. 3 really great presenters, really generous with their Q&A as well. So it's time for lunch. So we're going to come back at 2 o'clock. I think it's been a heavy session this morning, not in terms of but we've been at it for a while, not had a break. So let's come back at 2. Refreshed, ready to go for the second half. And thanks again for the speakers this morning. Brilliant. Thank you. Okay, welcome back, everybody. It's 2 p.m. Just want to bring you back into the session. So fundamentally, what I'm going to be sharing with you is a presentation that Annalise asked me to do to the, I'm just going to share my screen just a moment. Share to the research symposium. And the topic was on the user perspectives of research, or beyond clinical research, as we say. So effectively this was stories, not science. So that's how I'm sharing it with you right now, but there is some data and there is some science in it. So I'm going to share my screen. Hopefully you're all seeing that okay. Right, so let's make a start then. Actually, I'm seeing just get rid of that. There we go. So I may have mentioned it earlier today. I am a board trustee for PSP Association. I have been for 5 years, and it was about 5 years ago that I went to the first symposium, or not the first symposium, but the previous symposium, and I was completely blown away with the amount of research, the dedication, just overwhelming the amount of information investigation that was going into looking at causes and cures to PSP CBD, or CBS as others refer to it as. And oh, there we go. So one of the things I wanted to do in the presentation, or one of the things I'm presenting, is reminding people of the research strategy for PSPA, and this is our focus areas. So as a charity, we look to invest a significant amount of our funding, and even more going forward, into research. And our focus areas are these 5 that you can see. Now, clearly the first 3 are all focused around cause, cure, kind of clinical treatment, whereas the latter 2 in purple, you can see there, are more about how we help people whilst living with the conditions, and more importantly, equally importantly, the people who are caring for those people with those conditions. And how can we increase and improve involvement in research. And the strap line at the bottom there is, you know, how it's driven by people living with PSP, ensuring our best life. And it's interesting, some of the early presentations today talk about the best life and well-being, and that's certainly a topic that I'm gonna touch on. And so, if we think about well-being, I've done a bit of work in my non-trustee role with well-being technology startups, and we try and encapsulate it. And so this is a way of encapsulating it: our best life based on what we want to make of it, with the help where we need it. And the thing about well-being is it's often quite an overused term, misused term, confused term, and it's not consistent. But fundamentally, it's about mind and body health. And if you think about the conditions that we're talking about today, that impacts both the mind and the body, and we saw that in the presentations this morning. And if you're wondering how I got to become a trustee of PSPA, it's through that person in the picture, which is my mum. And right there, she's working on her well-being, which is helping me do bird watching. Anyway, you might see a little bit more of her later.
There are other things, but
so somebody's got their mic open. So if you are unmuted, if you could mute, that'd be great. Thank you. So let's think about well-being a little bit and let's unpack it. So in the context of PSP and CBD, so, you know, I'll let you read the kind of grey text, and I'll bring forward maybe the coloured text. So we think about it in terms of moving. So that's walking for hope, some hope every day. And again, we heard about, and we're going to hear a bit more about physio, but we heard from Boyd about the importance of physio. When we think about the mind, it was really interesting, that conversation we just had about reading. You know, actually the joy of using music and audiobooks, that escapism, is so important. You know, we talked about there comes a point where prisms just don't work, right? And we think about in terms of food, people would say nutrition or stuff like that in other, but food, okay? But attitudes and experiences around PEGs, vitally important when it comes to you know, people that are no longer to swallow for themselves. Rest, and this is where it's important to think beyond the person living with, even though they clearly have got disrupted sleep. But what about those carers? Okay, they're effectively doing shift work. I'll get to that a little bit later. But they're doing shift work after they've retired in lots of situations. And then fundamentally around social, the practicalities of one being out there and wanting to be out there. And we'll talk to that. And then CHC lottery, as I call it, and I think other people mentioned it on the chat earlier today. You know, what is it we do around money? Because money for lots of people, well, for everybody, is essential, but for people who don't have and need support, it's absolutely vital. We're going to come back to these a little bit later and think about what we could do in a non-clinical research, or some aspects of it are clinical. So let's give you some numbers. You know, I was at a symposium, so I had to give some numbers and some research. So I'll talk through the numbers. I'll let you read the narratives on the right-hand side. And one of the things in building this presentation is, apart from my own lived experiences and working alongside colleagues in PSP Association and other trustees, you know, I spent a lot of time looking and researching and hanging out on the various forums, reading the surveys. And in fact, I've read every single response to the patient survey, and it was both inspiring and heartbreaking to read those things. And I've taken some of those things and left them on the screen as you'll see them. But when we think about research and getting people involved in research, outside of providing awareness and support like we're doing right now, you know, our members want us to fund research and promote research. And actually, nearly 2/3 of them would really want to be involved in research. However, less than 1/3 have actually participated or are currently participating in research. So there's a gap there. And, you know, there's a number of reasons for that gap. That could be a bit of awareness, and we're desperately trying to increase awareness around research. But often it's eligibility, because more often than not, with a latter onset of the condition, being eligible for research sometimes is not quite there, particularly in some of those you know, other clinical studies, drug tests and so Which kind of brings into focus, and we'll talk about it a bit later, the real importance around early diagnosis, because it opens up a whole range of different things. And then if we think a little bit more about research, and again, coming back from our survey, think about two things here in terms of awareness and involvement and the role of the carer. You know, there was a lot of people that are unaware about the trial, so there's an opportunity there to improve awareness, and so that's things that we've already started to think about and try to do more on, but also the expectation that they would get this from their treating physician to inform them. And one of the interesting results we got from the research said that if they were going to be involved, they want to know about it. They kind of want to know what's happened. And it's interesting. So having sat through 2 days of this symposium where the most amazingly intelligent, dedicated people are sharing what they're doing, they're presenting it, the science. But often the people that are living with need the science, but they need a different user experience on it. They need to make it more digestible for them. But they need to know, and they should be informed. Interestingly, there's a real drop-off about not being involved if they're not communicated to. The other aspect of this, which was really quite interesting when thinking about user perspectives on research, is about what we need to do to support the carer. There's lots of research going in terms of, you know, the emotional need for the carer, the practical needs of getting people to and from, and equally down to the burden of decision making, because sometimes the carer, clearly, as we know, and further onset of the conditions, have to take sometimes decisions and what that means for them. And so supporting the carer is incredibly important if we want to increase participation in research. So one of the other things I mentioned about well-being, and there's a well-being thread that runs through this presentation, as part of doing our research with our PSP members, we've developed a theory of change. I say we, one of our exceptional trustees, James Noble, developed a theory of change. And our long-term goal is about people to live the best life they can whilst they have that. And there are a number of outcomes that contribute to that. Number one is clearly that they feel supported, that help is out there, they're not alone. And that support's going to come from a whole range of places. Yes, PSP Association. Yes, some of the materials and guidance. The incredible volunteers we have about 190 volunteers who just act as connection points between their experiences, the PSPA Association, and those people living with and caring for, whether that's a study group, a link volunteer, a whole range of different things. They are just superb. The accessing health and social care system, really, really important. Not a high percentage there, but actually if you look beyond the number and look at the narrative, just look at the chat, it's critical. And then the other one is about, living for the day and staying active and enjoying life as much as possible. And there are some, practical things to think about in actually doing that. And we'll talk about those things a bit later. So, we're trying to really understand well-being. And when you think about that phrase, I enjoy life as much as possible, when we did our research, these are the other things that kind of contribute to that. And so in a way, clearly it's about staying active, whether that's doing physio, whether that's having help and guidance support to get out there, to walk, to, change of scenery. You can see a number of these contributing factors. And then the other ones that are in purple here is around understanding of the condition and being in control of their situation. And it's really interesting, again, listening to the conversations we had on this morning's presentations around helping manage or signpost the condition and the expectations of the conditions. And so that comes in two folds, one in terms of providing that help, support and guidance, but also secondly, in terms of ensuring that as much as possible, we focus on that earlier diagnosis, because the earlier you know, the more things you can do. And you can only live your best life if you know what life you've got left to live as well. It was really, I'll show you a quick story. You wouldn't have seen the video. There was a video shared at the symposium. And in the video, there are a whole range of people that talked about the condition, how it's impacted their life. What struck me in one of the videos, a carer said, I would have just given up work and not tried to keep going had I known what I know now then. I would have just stopped it all and spent the best time we could have done. So when we think about in control of your situation, and we talked about improving participation in research, I was talking to one of the major pharmaceutical companies about a program that they're running. We were talking about who's eligible and those sorts of things. But one of the things that's clear is that they want people at kind of earlier stages for lots of reasons. Well, if you take this situation, these are the numbers that come from our survey. You know, and by the way, for those that are good at maths, you'll know this doesn't add up to 100, but this is how it comes out. But fundamentally, you get the drift, right? In 60% of occasions, it's misdiagnosed. And so the challenge with that clearly comes from in terms of finding a pathway, creating a support network and infrastructure. If you look at the slide that Boyd showed earlier around all the range of services that those people with PSP CBD should be accessing, you need to kind of navigate all of those things. And that also gets you to talk about the role and the importance of a specialist care coordinator as well. And again, one of the other things that you've got here is, what is happening. So that you've got verbatims at the bottom of the screen there. I'll let you read them. But fundamentally, what we're seeing here is that what people are given in order to start that journey is not great. And these are actual words from actual people that got actually diagnosed, and it's just not good. Okay, so how can we live our best life? What things are out there to do? And so one of the things we're trying to do here is just kind of think about well-being, living our best life, helping both patients and carers. And so this is the thing that's kind of driving us. And what are those little things can make a really big difference? And when we say beyond research, we genuinely mean it would be research, but it could be research and support opportunities. So again, be aware that none of these things are official policies of PSPA, but these are things that we're hoping we can think about in terms of inspiration of where we do research about people who are living with rather than causation or cure. Mum and I again. Actually, a little story about this. For those of you, this is Brillwyn Milks in Buckinghamshire. So we used to try and go to the high spots in the counties around us. It was just a bit of a thing. And actually, what you probably can't see there, but there's a camera on a tripod about 10 feet away to get us get us both in the picture, get the windmill in. And it probably took about 10 attempts to get this picture done. Either I was slipping up because it was a hill, Mum was looking in the wrong direction, or she was just looking in a direction actually, but it wasn't at the camera. And so, yeah, it just reminded me pulling this out for this presentation, just what a good time we had taking one picture. So how do we measure well-being? Again, this is really hard because it's kind of quantifying the unquantifiable. And I know there are a lot of the measures out there, but fundamentally, if we think about these 6 dimensions, and you could come up with any others, but let's say it's a mixture of those things for mind and body. And then maybe you take one of many, a Cantrell ladder. So we've got lots of opportunities these days. So there are methods out there. And you know what? We've got lots of good tools coming on board. Really, I know not everybody has the opportunity to use an Apple device or whatever, but this is what's come in the latest release of an Apple iPhone, where it's checking in on people in terms of their mental well-being. And this is only going to get better and better, and it's not just going to be one technology provider. There'll be lots of ways of doing this. There's tons of apps out there, in fact, to do some of this stuff. There's lots of opportunity to think about how you feel and why you feel that way. So let's just think about the little things that make a little difference. So what happens here is, if it's in purple, it's what the professionals say. That's you people, by the way. If it's in orange, it's what the people say. That's kind of me and people live with and care for. I know there are a good number of those people on this call as well. And by the way, for those people that are living with and caring for and you're on this call, it's all for you. So what they say, we know, I'll paraphrase it, right, that moving helps an awful lot. So yes, we've got people that are out there walking the Welsh coast that are absolutely inspirational, but it doesn't need to be to that level. It can just be about moving, stretching. We've got some great physiotherapists, one of our volunteers that runs kind of different kind of stretching groups and stuff like that, you know, getting people out. But it's not just the fact that they're moving. With, you know, what Boyd was saying earlier in the presentation about after people have been in a hospital situation, the impact that has on them. But it's just not only doing it on a daily basis, but equally what that means in potential for them to get out there and be social as well. So things that we could do, maybe we could have a wheelchair friendly walk publications, recruit volunteer pushers, use digital devices to capture all those things around mind well-being. And the impact of that is just, it's a sense of hope. It's a sense of, actually, I'm doing my bit. By the way, this 25 minutes my mum took to type that out on an iPad when we did the 5K Walk for Hope some, I don't know, 5-6 years ago. It was like, I think they called that bloody mindedness in Boyd's presentation earlier on today, but that was definitely on show there. Now, if we think about mind, I touched on this earlier actually, but fundamentally, there is tons of studies out there that demonstrates that music therapy, okay, stimulates the right parts of your brain. By the way, this is as scientific as I'm going to get, but we know that it fires off all the right neurons, okay? And in fact, we know, and I know from personal experience and from reading research, the value of that escapism, going out there, whether that's your favorite music or thinking about listening to Jodie Picoult, my mum's favorite author. But we know that. What could we do? Well, there are startups. I know there are startups. I help these startups in my day job. And, you know, we could look at EEG driven music therapy, even AI curated music. That's happening right now. And the impact of this, desert island discs. What do I mean by that? The impact is you don't have 3,000 records or episodes of a program where it's about what music would you take with you when you're in your loneliest place and in your darkest hour. That's potential impact. Little things making a big difference. And then we come to food. So this is really quite interesting. So if we think about feeding via a peg, the challenge is there are many advantages and disadvantages of that, and there are many perspectives of that, and some of them you can see on the left hand side in orange. But the reality is, could we do some kind of real life research and evaluation around what it's like to have a peg and not have a peg? Because I think that would be really, really helpful for people to make a kind of informed choice and understand what that really looks like. The other thing we could do, I know we do small gifts. We should maybe be funding blenders for people because, you know, we know the value in that consumption activity mentally, maybe being around a table. Food's important. It's important socially. It's a family event, okay? So how can we do things to help things like that? The potential impact, if you've never come across Tim Brown, you got to Google him. The ice cream challenge person. What an inspiration he is. Just demonstrating that he's not going to be held back. And the range of ice creams he is just incredible. So let me come to rest. And again, a bit of science for you. It's scientifically proven that shift work impacts your physical well-being and potentially can contribute to major conditions going forward in life. Let me give you an example of what shift work is, because the definition of shift work is if you're active for 2 hours between the hours of 10 p.m. and 5 a.m. So that's train drivers, bakers, nurses, doctors, clinicians, carers, okay? They're doing shift work. So could we do observational studies around shift work? There are lots of sleep tech things that we can do today to figure out what is happening. Yes, the person that's living with, but more importantly, the person that's caring for. And the flip side of that, right? I've mentioned that often the primary carer is a partner. The primary carer, therefore, is towards the end of their working life, or as started maybe a retired period of their life, and they're going back to doing shift work. And of course, we know, you know, that when you are in that caring role, the pressure and the stress is a lot higher, plus the condition, the way it displays in terms of, we mentioned the bloody mindedness, but we mentioned the other aspects and the variation of emotions and so on. There's an awful lot to deal with, and definitely not having a hard day's night is something, if we can find out about that, put together, understand it, and there are certain interventions and guidance that we can do to help with sleep, that could be a little thing that could make a huge difference. And it's not always about the person living with. So lastly, we come on to social, and this for me is a bit of a polemic topic really, which is this is around catheter, for example. So one of the challenges you've got for your body and mind well-being is if you're staring at four walls every single day, and by the way, that means the carer will often be staring at the four walls every single day, that's not a great situation. And I can recall a situation which is we had to make a call, which is, do we catheterize, not catheterize? Catheterization, and I know it comes with lots of other challenges around infections, changing, smell, loads of other situations here. But what it means is sometimes you can live your best life because you're not worried about the 20 minutes you're going to be in a car to visit relatives or friends, or worried about being at a place where you are enjoying a social experience, a cup of coffee, a cake, or whatever it is, probably an ice cream, without there being a accident and having to solve for that accident. We could do some real world awareness around this. What are the advantages, disadvantages? Tell real life stories. Lastly, money. So that's why I touched on the CHC thing earlier. It's absolutely distressing to read the comments around people's journey on CHC funding. It should be better, it should be cleaner. And as I was saying to Boyd earlier, you know, it's deteriorating at a rate a lot quicker than the process supports it today. Could we then have a best practice guide on how to get the message across? Could we almost have cut and paste, I know it's different, principles? I know we write support letters, by the way, that was on the chat earlier. Thank you, Sophie, for pointing that out. But could we have something that's best practice to help people? Because not everybody may be aware of that, and maybe not everybody is making use of that. And then we should measure the effectiveness of those funding approvals and see where we get to. And you know, the potential impact of that is really practical stuff and emotional stuff. And I'll let you read the comment on the right hand side in terms of, you know, what that meant for somebody. But you know, I had conversations with people at the symposium where, you know, genuinely they got funding 3 weeks before the end of life, and actually that was too late. And sometimes they got approval post, and again, that's not great either. So lots of stuff we can do. The great thing is, I know this isn't about a cure, I know this isn't about causation, but it's about living with. And a lot of people are going to be living with for a lot longer before we get there. So what can we do to live our best life? And there's so many ways to participate. Yes, traditional ways of analog discussion, but we've got so many things around digital and devices that we can help increase participation, learn, support, and so on. And then we can join up the dots, make every day a little bit better. That's what we're going to do here. So last comment in here, participating in research, whether it's a clinical trial or not a clinical trial, gives a degree of hope. The other thing that come out of all the verbatims I read is this degree of having control, that they are controlling what's happening to them in some shape or some form. A little victory. Okay. That was it. This is living our best life. That was what we shared with the symposium. So I'll take any questions if you want to do questions, and then we'll hand back over. I haven't seen the chat, by the way, because obviously I've been looking at the screen, so I'll get Mum off the screen and then go back to the chat. Actually, Carol, as you've been watching the chat, do you want to ask any questions if there are any questions to me? If not, we'll move swiftly on.
I don't think there are any in the chat. So should we move on to Jade?
Just the way I like it. Yes.
Yeah. And if any come in, we can get back to people later. Okay.
Not a problem. Jade, are you ready?
Bless.
I hope so.
All right,
Time will
okay.
tell. I'm on a different computer in a different office now, and I've tried to set things up differently. So just bear with me. I will share my screen and see how I get on. All right.
Okay, no problem.
Perfect, lovely. All right, let's take two. Hopefully this will all go smoothly. So as I said, my name's Jade Donnelly. I've got, for the last 6 years, I've been working with patients with PSP and CBD, and I've had the privilege of seeing hundreds of patients with these conditions over various stages of the course of condition. And that, I think, makes my role quite unique. So I'd like to share some of what I've seen and what I've learned from both spending time with patients and their carers, and also spending time with a neurologist that I work with, Dr. Ghosh and Dr. Luke Massey. I believe that we can make a huge difference to these patients and help with their quality of life. So hopefully, these are my disclosures. And this is what hopefully I'll be covering today. So I'm going to be looking at the evidence. I'm going to look at aging. We're going to touch on some deconditioning, and then just some general thoughts and observations. I'm going to touch on the workforce, so our resources with regards to that. And then I've got some case study videos, and then I'm going to finish up with some future plans and a summary of what I've covered. So, patient and carer partner views on exercise and structured physical activity for people with progressive supranuclear palsy. So people from this study, and I think from my experience as well, people with PSP are keen to participate in exercise, especially early in the condition. And I think other professionals will probably agree with that. What this paper highlighted, that people with PSP were rarely referred for therapy and had to seek it independently. Now, personally, I think we're probably slightly better than that, but that's what they found in this study. People with PSP were uncertain about what activity and exercise would be helpful and at what dose. And I think that's absolutely true. For what is best, what should they be doing? And then they found certain barriers to this, and some of that was carer burden. In particular, they highlighted the challenges of navigating the system. Now, it can be a complex system. Where do I get my physiotherapy? How do I get referred into it? How do I seek private physiotherapy if I want to do that? How do I know that's going to be the most appropriate therapist for me? And I think there are other barriers to exercise as well from a carer's perspective. I think we need to think about maybe the age of the person involved and the age of their carer. That might have an impact, and that might affect their ability to navigate this complex system, let alone the actual physical act of maybe getting them to where they need to be geographically to participate in activity or exercise. So this paper looked at the enablers to exercise participation in PSP from a health professional's perspective. And what it found was that nursing staff and allied healthcare professionals believe that exercise, physical activities, movement rehabilitation are important in enabling those with PSP to live well. And I think we'd all agree with that. There was some uncertainty over how to deliver this and how we should do it the best way. And there was a lack of evidence as to the resources, and that was seen as a barrier by healthcare professionals. And this paper really highlighted the need for clinical guidelines for these conditions. And I think we'd all agree that exercise is good, but sometimes we're not sure of what exercise or how we should be delivering it. A recent paper by Respondic in 2023 looked at the lived experiences of people with PSP and their caregivers. And the paper highlighted that physiotherapy had been beneficial to patients, but also highlighted certain things, in particular that communication was sometimes challenging between the healthcare professionals, and there were educational needs for therapists in relation to how they should best manage these conditions. So what do we know? We know that exercise is good. We know that there are effects of aging and muscle atrophy if we don't use our muscles, and as we get old, the effects there are. And we know there are effects to inactivity and deconditioning. So I'm just going to talk about these a little bit more. So exercise and physical activity. So there's limited evidence to suggest that physiotherapy is helpful in PSP and CBS or CBD. There was a big systematic review done by Slade et al. In 2029, and I've talked about that in previous presentations. And it highlighted that although exercises may have the potential to benefit people living with PSP, currently there are few studies that adequately report all the key elements of exercise therapy design and implementation and assessment. There are, however, numerous papers that look at physiotherapy for Parkinson's disease, and obviously there are the European Parkinson's disease guidelines, and there's numerous studies, but Rader et al. In 2020 was one I looked at, and there is numerous studies looking at the aging population and the benefit that physiotherapy can be. So we also know that there are benefits of remaining active, and both the physical benefits of remaining active, but also the mental benefits of remaining active. And we know that physical inactivity is a key contributing factor to sarcopenia. So sarcopenia, the loss of skeletal muscle mass and strength as a result of aging. And this can have, or it can be a key contributor to frailty. And I think the other thing to think about is incorporating functional activities such as sit to stand can be really, really helpful. And papers have shown that resistance and power training is important. And we know that there is a loss of muscle power with aging caused by fast twitch fiber atrophy and changes to neural recruitment. And I think with any activity, we just need to be aware of what we're advising, and just to be aware that patients with PSP certainly can be impulsive, and we know they have postural instability. So we just need to have those things in the back of our mind when we're thinking about what we're going to prescribe for them and what would be best. And I'll talk about that a little bit more later. So someone was asking questions earlier in the chat about splints, and I think splinting can be really useful. I think it has to be assessed on a person by person basis. So the carrot splint there, bottom right in blue, it's a pneumatic splint that you pump up after placing it in the palm of the hand, and that can help just prevent that hand being maintained in a clenched position. Palm protectors are useful, but again, I think someone commented sometimes they're a bit flat and they need to be plumped up, and I think that's absolutely fair. I think it depends on how much contracture and loss of range there is. And this is an example of a care plan that was provided for a patient in Dorset by one of my colleagues that works down there. And this was really beneficial. So this lady had corticobasal degeneration. She was developing elbow contractures and shortening in range of movement. And the splint was really helpful. But I will highlight that it took quite a while for carers to become comfortable and confident in the way they donned and doffed the splint. I think all too often we might take it for granted how obvious it is, but these might be challenging tasks for carers to undertake. So we just need to allow time and education and clear instructions so that it can be done well to be effective. But I do feel they have a place to play in the care of patients with these conditions. So evidence for physiotherapy. Currently, most evidence is looking at what intervention is best. And there's been various studies that have been reviewed and looked at with regards to PSP predominantly rather than CBD. And they've looked at treadmill training, robotic arms, there's the study by Zamperini looking at gaze and balance, the studies looking at strength and flexibility. And some of these studies are relatively small with few numbers. And I think there's such variability in what sort of studies are undertaken. And I do wonder whether we need to change the way maybe we look at the evidence or how we explore physiotherapy intervention, and compare what happens if patients receive little or no therapy and the impact that has on a patient. So with that in mind, I'm going to move on to hospital-acquired deconditioning. So up to 65% of older patients experience a decline in function during hospitalization. Many of these patients could prematurely end up in care homes because of deconditioning and a loss of functional ability in the hospital. And that's from the British Geriatric Society. And this is for the normal aging population. And there are many factors which have an impact on hospital-acquired deconditioning. And a meta-analysis done by Smith et al. In 2020 highlighted the many challenges and multifactorial problems healthcare professionals face when managing these patients with in the acute setting. And some of those things might be the healthcare professionals not wanting them to fall while they're in hospital, so they're kept in bed to stay safe. From a patient's perspective, it might be a fear of falling, and so not therefore wanting to mobilize. And I think the other thing is some patients out of their usual environment, they're able to function less, and the list goes on. But I think we need to be hugely aware of this. Now, we've been looking at deconditioning in amongst our client group, so atypical Parkinson's patients, those with PSP, CBD and MSA. And we're looking at the effects of deconditioning in this population. And we're comparing those patients who've been admitted with condition-matched patients who have not had a hospital admission. And the results are still being analysed, but preliminary data suggests that there is a difference following admission. So for the PSP patient, most notable was the change in mobility. They were mobile on admission and they required a hoist on discharge. The patient also required a catheter and a rig fitted during that admission. So when we analyze this a bit further and we look at this data, when we look at their PSPRS, so the PSP rating scale, a scale used by clinicians to assess how the conditions progress, the score increased by 19 points in a 14-month period. And to put that in context, what we'd usually expect is, from the literature, they suggest a 1-point increase for every month. And usually we talk in clinic about a 10-point change in a year. So that's a considerable change for these patients when they've been admitted to hospital. I think it's important to be aware that this is a small scale study, but I do think it highlights the vulnerability of these patients to deconditioning when in hospital. But I also believe there are many contributing factors which need to be considered for these patients. I think we need to think about how these patients might not be in their normal routine and have their new normal way of doing things set up around them in a very, they might not be in their normal shoes. So how often when patients are in hospital, are they wearing the lovely grippy socks that we provide them, whereas maybe normally they wear a wedge shoe to help with their postural instability, to help them maintain their verticality. So I think we just need to think about all the subtleties of the change when patients come into hospital. Is it miles away to the bathroom? And usually their bathroom is much closer to them. So I think these are things we need to think about. And so what can we do when patients are admitted? So I think we need to encourage activity where appropriate. There might be a reason that we don't want them to mobilize, but if there isn't, then I think we should encourage activity. I think we need to educate other members of the MDT. And I think we need to be very much aware that these patients are at risk of hospital-acquired deconditioning and taking a proactive approach. And where possible, I think we should look at early discharge planning. If at all possible, can we avoid the admission? And sometimes we can't. Sometimes there are planned admissions for a procedure. And then I think we just need to be aware, if they're coming in for a planned procedure, how can we make it as efficient as possible? So I'm just going to tell you a little bit of a case study now. So we recently reviewed a patient on the ward. It was a new patient we hadn't met before. We'd been asked for a second opinion, and I went along with Dr. Ghosh, and he made the diagnosis of PSP. So the patient lived alone at home and had come in due to a fall and a long lie. And looking through his notes and his records, he'd had 3 previous admissions with long lies in the last 4 to 6 months. So during this admission, we tried to educate the carers about PSP. We talked to the patient, obviously, about the condition, and we highlighted to the ward about the risk of deconditioning. And there's always a challenge. And the challenge with this patient was we didn't want him to decondition, but he was hugely impulsive. And unfortunately, he fell and he fractured his hip, thus extending its stay even longer in hospital. However, he did get discharged, and he was discharged to a care home, and he was mobile. But that also was challenging because initially he was put to return to a discharge home with a QDS package of care, so a 4 times a day package of care. And it took quite a lot of work from members of the team to highlight that actually that wasn't appropriate due to 3 previous admissions in quick succession due to falling, due to his impulsivity. And I think this case really highlights the complexities of the symptoms and problems these patients have and the need for understanding of these rare conditions. So at the symposium, they shared, a recent symposium, they shared this observation and this description of written by Charles Dickens. And I'll just give you a moment to read it. How clearly is that description so clearly depicting PSP? The way he describes the gaze palsy and the standing to sit pattern of those with this condition, and how often do we see that crashing down into the chair? And as physiotherapists, I think we have one of our skills is our observational skills. And so what I'd like to talk about now is the physio guidelines. So hopefully you'll be aware that we've written the physio guidelines. Myself and 4 other therapists worked on those, and they've been out now for probably just about a year or just under. And hopefully you've read them. Hopefully you know they're there. You may have referenced them, you may have used them, and I hope you found them helpful. And when we were writing the physio guidelines, we had to think about, do you need to be an expert in these conditions to effectively treat those in your care? And I have to confess, initially, I was very much, absolutely, of course you do. And then I reflected on it. And after discussion with the other members of the team, we decided, well, actually, no, you don't. Because how often do patients get seen by therapists in the community where they might have been given a diagnosis of Parkinson's disease and still have that diagnosis, because we know sometimes diagnosis can take a long time, and they've been treated effectively and managed, although they might not be responding the way we would anticipate if we thought they were Parkinson's disease and they weren't, and they were PSP. So I think physios are really well placed in the community to pick up on these things. I think sometimes there's a fear with rare conditions from therapists about treating rare conditions, and whether that's due to their lack of knowledge or experience. I think as therapists, we're always wanting to do our best by our patients. I think one thing to be aware of is maybe knowing the red flags. I think these were briefly mentioned earlier, but I think they're good. These charts that I've shown here, you can access them on the PSPA website. They're a quick reference, and you can quickly look at those and think, oh, yes, that is normal for this condition, or that is something that I wouldn't expect to see in Parkinson's disease. I think the other thing to think about, and we talk about these within the guidelines, is that we talk about PSP and we talk about CBD, but also there are many different phenotypes of these conditions. So there is PSPP, so PSP Parkinsonism, and that can be slower, for example, in its progression than PSP Richardson syndrome. a patient may present with PAGF, so pure akinesia and gait failure, and they may struggle more with freezing a gait. There might be patients that have a PSP and a CBD overlap. So there are many different phenotypes, and sometimes it's good to be aware that they are different phenotypes. I think you can always refer to other information as to what you might expect to see and find with these conditions. So I'd like to talk about my second case study now. And this is a patient that was diagnosed with atypical Parkinson's syndrome. For the purpose of the case study, I don't think it matters which condition he was diagnosed with. And I received a call from a family member who was really concerned. The person in question had been mobile, they had a wide staggering gait and had falls. But at the moment, and for the last few weeks, they'd been in bed and they were having carers now 4 times a day. And the carers said, but was concerned because 2 weeks ago they were mobile, they were much more independent, and now he was needing a lot of care. And for me, that made alarm bells ring, because what I know and what we're aware is that these conditions don't change overnight. They're progressive, they will get worse, but they won't change overnight so dramatically. So I was concerned. I spoke to the neurologist. The neurologist spoke to the carer, and the patient was blue lighted in and brought into hospital for a CT scans because we needed to see what was going on. Was this a UTI had made the changes? Was there something else going on? But what we were aware is this wasn't normal for the normal progression of this condition. And I suppose it's important to note that in the community, when asked, you know, what do you think is going on, it was very much his problems were put down to his atypical Parkinson's syndrome and it being progression of the condition. And I felt personally that wasn't quite right. So this was the CT scan. So I'm not expecting you to be an expert in reading scans, but hopefully looking at that, you might be able to spot some differences there. And if you're struggling, I'll give you some clues now. So we can see that there's the ventricle, we've only got one and we should have 2 because it was being compressed. And we can see either side in those red circled areas that there's some blood there. So this patient had 2 chronic subdural hematomas, collections of blood. He had burr holes to one side, not both sides. And he is now rehabilitating. And I raise this case study because I think it's really important to listen to family members. I think so often they're giving you the information they need. And also I think it's to be aware of, know what is normal for these conditions. Now you might not be able to know everything about them, and I've talked about there being lots of different phenotypes. But I think one thing to think about is they progress over time and they don't change overnight. And for this man, he changed very quickly. And that should make alarm bells ring that something else is going on. Now, not everyone who changes overnight is going to have a subdural. There may be something else going on, but just be aware that they don't change dramatically overnight, and there might be another reason for it. So physiotherapy, why have I put this slide up? Marmite. I think physiotherapy, patients like it or they don't like it. And I wonder, why is that? Why do some patients really not get on with physiotherapy? And is it because they've had a bad experience? Is it that we don't meet their expectations? I find in clinics sometimes patients will go, "Oh, no, I didn't get on with physiotherapy. It wasn't helpful." And it just made me think, why is that? And I think so often people have this perception of what physiotherapy is. They'll say, "Oh, you're a physiotherapist. Oh, you'll look after my back," you know, and they'll think about the musculoskeletal problems. And often physiotherapy is looking to treat or cure a problem, so a soft tissue injury, and would rehabilitate you back to function. And whilst in the early stages of these conditions, we can work on balance and gait and potentially make improvements, as these conditions progress, we're looking more at the management and maximizing function, and in the later stages, maybe postural management and comfort. And I think as therapists, we need to be really clear in what we can provide and not give false promise and hope as to what we can deliver, so that patients are really aware of how we can help them, because I do believe there is a lot that we can help them with. I think another challenge that we face is that we have limited resources. There are only so many physiotherapists, and this recent review by the CSP looking at the number of therapists in the UK to the rest of Europe shows that in the UK there's one physio per 1,100 people in the UK, compared to 1 per 410 in Germany, and that's a stark difference. And the same for in Australia, there's 1 per 700. So how can we use our resources better? Can we work differently? Can we work smarter, not harder? And I think it will come as no surprise that the needs of patients with atypical Parkinson's disease are very different from someone with a slower progressive condition like MS or maybe PD. The intensity and how much they need, the demand they put on the service is going to be different. And we need to look at how we can manage that effectively to respond in a timely manner. We need to think about future-proofing our services and planning ahead, because we have an aging population and the challenge is only going to increase. I don't think there's an easy answer to this question, but I think we need to think about it. You know, can we refer these patients to group activities? So locally we have a Steady and Strong. Are there online classes that they can participate in? I think we just need to be aware if they're really impulsive or they've got quite marked postural instability, how we manage that and how they can do it effectively. But maybe we sometimes need to think outside the box for these patients. I think also sometimes simple is good, so keep it simple. Patients often struggle with sit to stand and stand to sit, the classic rocket sign of them getting up and the classic crashing down into the chair. And I'm going to show you some videos shortly. I think a problem area and an area we can work on is that trunk flexion, that bending forwards, which is often lacking in PSP. I think a step stance, a step standing position can be really helpful, both for standing up, but also when in standing to help with that postural instability. So when, for example, you're opening a door, opening the fridge door, if you're in that power stance, 1 foot forwards and 1 foot back, you may be more stable than having 2 feet next to each other. I think encouraging patients to work on building up that momentum may also help with their sit to stand, and cueing may or may not be helpful. Some patients get on really well with cueing. I think other problem areas are rotation. So we know that patients struggle with axial rigidity. So if we can incorporate rotational movements into our physiotherapy, I think that's really important. And in particular, using functional activities, so rolling over in bed can be helpful. So now I've got lots of videos and I really hope these come through clearly for you. So this is our first gentleman. So I'm just going to give you a few minutes just to have a look at the way he's standing. And you can see that his weight is really in his heels. There's a lot of effort through his upper limbs. And if the sound was on, you could hear the effort of him trying to get up. But he did it, and he did it independently. But that was hard work. And I think hopefully you can see that there was a lack of trunk flexion and anterior weight shift. Now, one option people might think in this position is, well, we could use a riser recliner. And I think riser recliners are really helpful, but I think they have a place. But I think sometimes if we look at the biomechanics and can we alter that, we can make an improvement without maybe using a riser recliner. I certainly do believe they have a place. I just have to think we should consider when we implement them and when we use them. So this is now him trying to work on a little bit of momentum to get himself up. And you can see the effort was far less. He was over his feet much more, and it was much more efficient for him. And that was just a very short session looking at sit to stand and working on momentum. And a small change made quite a big difference to him. And sometimes it's the simplest things that will make a big difference for these patients. I think other things to think about that might impact on the sit to stand, stand to sit is range of movement in the hips and knees, like we've discussed, but motor sequencing, depth perception, certainly those with CBD may struggle with that, and also being aware of the down gaze. If they've got that gaze palsy, that might have an impact on it. So my second video. So I talked about cueing and different cueing for different patients.
1 foot forwards, not too far forwards, 1 foot back, bend in the middle, and stand. Good man. Now find that.
So ready, steady, stand, 1 foot forward, 1 foot back. But sometimes cueing can make a real difference to patients. So it's just worth thinking about that. And I think just tying in, I mentioned it earlier, working on balance and gaze. There's a study by Zamperini that talks about that. That might be a useful thing to consider when we're looking at balance training. Okay, so roll this video. This is another lady with PSP. You can see there's a lot of weight into the backs of her heels and she falls back down. It's hard work. We reset up to go again. She's got quite a wide stance. I encourage her to build a little bit of momentum to help with the sit to stand. And again, she's holding my hand quite hard. She's working quite hard to be there. You can see how her right foot is lifting off the floor. Her weight is very much back. And it takes her a while then to steady, to feel happy, to then let go of my hand before she then sits down. So I'm going to roll another video now of her a few minutes later.
Okay, so you're going to push on the bed. We're going to do the ready, steady, stand. So, ready.
So you can see that she gets up much quicker, much easier. She's more confident. She leaves my hand and steadies her feet far more quickly than in the other video. I can't see the chat, and I was going to ask you to make a guess at what I changed, but for fear of disrupting my presentation, I'm not going to do that. So the difference in this video, some of you may have already guessed it, was heel wedges. And it made an immediate change to the way she was able to manage her postural alignment. So I think heel wedges are really, really useful. I think if you are going to use them, I think you just need to be aware what happens when the patient isn't using them, because they will become more reliant on them. But I think they are exceedingly useful and very easy to slip into someone's shoes. And for this lady, it made such a dramatic difference to the way in which she managed her sit to stand and how confident she was with her movement. So this is another gentleman with PSP. So this gentleman had come in to see me, and just prior to coming into the consultation room, he had fallen in the waiting area due to his mobility. Turning is often a problem for these patients, and you can see how he struggles with that. So whilst he was in clinic, we thought it might be helpful to try a different walking aid. So we tried the U-step with him to see if that would help with his fluency of gait and his confidence and stability. So this is the same video of the same gentleman that we saw earlier who was struggling with his sit stand, again using that momentum, that rocking action to help him with his sit stand. And this is him walking with a U-step walker. So for those of you who aren't familiar with the U-step walker, it was designed for patients with PSP in mind. It means that you can pretty much hang on it and it shouldn't fall back on top of you. And it's got a very tight turning circle. Now, some patients may get on with a standard four-wheel walker. Sometimes the problem with a standard four-wheel walker, I find, is that it can run away with patients, or if they fall, it will come with them. and I've had a go hanging on the back of this to see if I can make it tip, and I haven't been able to. But and they also have the option with the step water of a laser, and I wondered whether the
And then
laser would help
turn.
this gentleman when walking. And it might have made a subtle difference, but I don't think it was dramatic enough to say, do you know what, I think you really need a laser cue. I think the other thing we need to remember for patients, if we're going to suggest a laser cue, is that they've got to have the ability to look down and see the laser to help it be effective for them. So this lady has, I'm just aware of time, this lady
When you're
has
ready.
CBD. This is courtesy of a colleague that works down in Dorset. She's using a ride as a recliner. She'd been asked to go out and review this patient at home because she was falling multiple times and it was becoming problematic. And her main risk area was when she was turning, and you'll see in a minute that she turns quite quickly. I think normally it's even quicker, and that was when she tended to fall. So it was thought that actually, why don't we try a gutter frame with her? And we'll move on to that video shortly. I just also to be aware, when you go into patients' homes, they'll have animals, they'll have they might have toys for the pets on the floor, but we're working in someone's home, and so we have to be mindful of that, but be aware of the obstacles that might be there that limit mobility. So this is this lady.
Okay. So
And what you can see is while Kira's trying to help her set up, she's really struggling to work out where she needs to put her arms. And she got quite frustrated and agitated with this. So the assessment was stopped fairly promptly with the gutter frame, and that's due to her apraxia of movement. And so I suppose the message here is sometimes aids and equipment aren't always helpful, and sometimes less is more. And sometimes we might need to think about a different way of doing things. So this is another lady that has
to the chair.
PSP. She was very impulsive, again, a frequent faller, and the therapist had gone out to try her with a different walking aid. And you can see now as she walks across the room, you can just see how that right foot's pulling up. She catches her foot and she's sort of saving herself by touching on the windowsill. And this is a lady that was falling frequently. So she had a trial with a four-wheel walker, which gave her a much better walking pattern, but it was quite hard negotiating around her home environment. But she was far more stable with the walking frame. But as we continue to watch the video, you'll see when she gets to the end of the corridor, she ditches the walker, which is not uncommon, and opts to walk without the walking aid. But you will see there's some really nice handy grip rails in place that for her were a better option, and she found it better and easier to use those rather than the walking aid. So Brown et al. In 2020 highlighted that frequent fallers have been found to have disproportionately poor performance on turning and pivoting. And I think that's an area that we could really work on within maybe a physiotherapy treatment or intervention. And as I've mentioned, walking sticks and walking aids may reduce falls. However, they may be a trip hazard. And they may not necessarily be the answer. So I think we need to carefully assess whether it's helpful or not to use a walking aid. And I've shown some instances where they were helpful, but I've also highlighted when they weren't. Falls. So we know that falls are a really big problem in PSP and CBD, and they result from multiple factors. So axial rigidity, bradykinesia, so slowness of movement, freezing of gait, reduced or absent postural reflexes, visual vestibular deficits, impulsivity, and decreased insight. And Brown highlighted that frequent fallers have been found to be disproportionately poor at turning and pivoting. So I think it's really important to look at how patients get off the floor and give them some education about that. So using the backward chaining, and also think about the way in which patients turn. So can they do a side step? Can they do a U step? So walking around in a U, and moving away from that pivot, that twist, that quick movement, which might be where they become unstuck and fall. A study by Kate Blanford highlighted that many challenges that physios face when working with patients with atypical Parkinson's conditions. And she highlighted the very many complex skills therapists had to acquire. And some of that was around rephrasing how we look at things. In particular, you know, it might not be that we're looking at getting better, it might be that we're looking at improving quality of life and maintaining function. Or it might be that we're not getting back to normal, but we're adapting and coping with the condition, but helping to maintain control or give the patient some control within that. And whilst these are very challenging conditions, I believe that our listening and observational skills, there is much that we can offer these patients along the course of their condition. So when thinking about the future, I'm really excited that the PSPA have funded a 2-year project for us to set up a Wessex network. So Wessex being Dorset, Wiltshire and Hampshire. And that's going to hopefully help improve the knowledge and communication for healthcare professionals and improve the lives of those living with these conditions. It's going to provide monthly meetings with advice from a panel of experts. This will all be virtual. And then there'll be study sessions for members of the MDT, and those will be profession specific. So I would say if you want to be part of that network or find out more about the network, it will only be for those within the Wessex region. Please do email and we will add you to our mailing list. So in summary, draw on the available evidence and resources that there are. Communicate with members of the MDT. There are often many professionals involved in these patients, and I think we just need to make sure that we communicate with each other so the patient is at the centre of what we're doing. Use our observational skills. That is what we're exceptionally good at as physiotherapists. Listen to patients and their carers. They're often telling us and giving us all the information we need. Keep it simple. Use functional things. Signpost to other resources or services. Join the network and utilize the PSPA. They have a wealth of information and resources and can direct you to professionals who may be able to advise you if it's not on their webpage. And ultimately, what I want to avoid is that hearing this, you have a progressive condition and there is nothing that we can do, because I believe there is lots that we can do, and hopefully I've demonstrated that to you. So just a final thank you to the consultants I work with, Boyd and Luke, who I've learned so much from. Thank you to Rui, our clinic nurse, Zoe, my secretary, the research team who do some fabulous research with us for these patients, Farah and Annabelle, the students looking at our deconditioning and other projects, Kira Baker, who also supplied some of the videos and the PSPA. But most importantly, I'd like to say a big thank you to the patients and families with PSP and CBD who shared their experiences, agreed to videos, and have supported our ongoing research. So thank you.
Fantastic, Jade. Wonderful presentation. You don't get off lightly. You still have a few questions.
Okay.
So we have a few, and then so the first one, this may be a quick one to answer, from Jackie Hill. What was the arm splint called?
Oh, I will have to get back to you on that one's name. Sorry. Yep. No, it's not on the tip of my tongue.
That's
I'm
okay.
sorry. Yep, but
No
I will
problem.
give you the name. Yep.
We're not sure whether this got answered in the chat. We want to check. So Helen Coleman said, who would supply the carrot pump?
So the carrot pump, the pneumatic carrot, you can order them online. You should be able to order them through your equipment stores. I would suggest certainly your OT or physio should have access and the ability to do that for you. Yeah. But they are available online. What I would say is I think it's better if patients don't independently purchase these things. If possible, it's quite good to have a professional give you some guidance on how to use them. But your therapist should definitely be able to order them for you.
Okay, and last question, although there might be some extras on the chat, but last verbal question from Kathleen Eddy, which was, do you find there is a difficulty with carryover and retention of skills between therapy sessions?
Absolutely, that can be a problem. And we know that taking on board new information can be really hard. And I think that's sometimes why we see with the walking aid, while we're there and prompting, they use it. And then actually when we're not there, they ditch it. So I think that there can be a challenge with that. I think for each patient, everyone's an individual. We need to assess individually and see what their problems are. But yes, carryover can be challenging.
Thank you, Jade. Fantastic. So we're going to move on now to final presentation, which is for Annalisa Casarin, who we're sad to say is leaving PSPA today from a research coordination role. She's going on to do her own research. And so she goes with all of our thanks, blessings, and love. But before she did, she leaves us. She helped coordinate the fantastic research symposium a few weeks back. And I think you're going to give us the highlights and insights, Annalisa.
Yes, thank you. Can you hear me all right?
We can hear you.
Yeah, sorry, I'm in a public place, but it's a bit quiet. So finger crossed there's no too noise in the background. I share the screen. Let me know when you can see it, please.
We can see it now.
Okay, good. So yes, as Paul, thank you, Paul. And on the introduction, as he was saying, I was asked to basically provide some insight on what we learned at the symposium. Actually, there is a lot in there. And of course, the slides don't move. 1 second. That is gone. Yes. So the presentation will be much more about new discoveries and approaches and what we heard from amazing speakers from all over the world, but also will point at, of course, the need of patients' participation, the importance of public involvement, and also that PSPA, as Jade mentioned, do provide grants for professional development as well and projects. So at the symposium, we heard about a lot of things. I know it's the last presentation of the day. I try to be light touch, but it's quite an in-depth analysis of what is going on in the brain. So we heard about tau, of course, and all that is around brain cells, so synapses, mitochondria, astroglea, and then the inflammation was the big also topic of the symposium, plus what the Professor James Rowe often refers at as a domino effect in PSP and CBD. When you start something going wrong, then everything else is just going to progressively deteriorate. So we need to stop that. And we look also at diagnosis and why it's difficult to actually make a diagnosis, the environmental factors, stages of disease, so the clinical management and outcomes, potential outcome for trials, and so on. But I wanted to just give a quick visual aid to see what is the neuron, is the one on the top. And of course, there are like many other parts of it that could have a degeneration. And also there are many other cells around the neuron, including the blood vessels and the microglia that, again, could be potential also way to diagnose a disease. And this in details is where we're going to lightly, let's say, touch today, is about genetics. So the nucleus, where there are chromosomes and genes, the mitochondria that are helping with storing and releasing energy, the tubule, of course, where tau is normally working, keeping together the fibers, and the synapses that is up there with all this ramification from the cells. And we know that tau now, we know that tau goes more centrally in the cells and to create these tangles and have some disruption in the center of the cells, the neurons, while in CBD is more peripheral, so more close to the sides of the cells. And we know also that the tau that is the culprit in PSP and CBD is the 4 repeated tau. So an isoform that actually shows great heterogeneity between PSP patients especially. And so we got many molecular subtypes. So one of the idea of diagnosis is not only going for clinical differentiation sorry, the clinical differences between the phenotypes, but also the molecular issue, like the molecular changes to make a better and quicker diagnosis. So you will get the PDF for these slides, so you will have time to actually explore this a bit. This there was a talk, the first talk of the symposium actually was by Professor Lang from Toronto, talking about what's happening in the last, what has been happening in the last 25 years. Now we are at the end of this arrow, and the idea when this paper was published that was that we were looking at genetics, environmental, and post-translational factors, and we are doing that. So one of the, again, one of the main topic was inflammation. And if inflammation is actually an effect of the normal aging of the brain and the predisposition of tau to go wrong, or actually the neuroinflammation is a consequence of neurodegeneration. I think the answer is like both. And we have here like what's happening when there is inflammation. And also is, well, you're all clinicians, so you may know about cytokines and some of the names there you can see in these slides. So there is, of course, the question, can we tackle inflammation? And so can we stop neurodegeneration? And of course, we need also to detect there is inflammation in the brain. And so we need specific biomarkers and radio tracers where we can look at the degeneration in the brain due to inflammation. Again, just a quick reminder how things looks like. So we got tau and we got cytokines. So this is just an easy diagram, let's say, where you can see how things can go wrong. Not going through this in details, but it's just to show how complex is the situation and how many more cells that we thought before are actually involved. So what actually Prospect has been doing, Professor Hugh Morris, his team in UCL, and also the link with the global organization called GP2, is looking at tauopathies. And they discovered there is regional variation, like geographical variation in tauopathies around the world. And also there are some familial and monogenic tauopathies. There is also a strong association between infection disease and development of tauopathy. And Professor Coran Duff also included there repetitive mild head injury, seizures, and autoimmune disease as one of the potential, as some of the potential risk factors. So again, through the Prospect collection of data, Professor Hugh Morris also discovered that tauopathy can be identical to a Lewy body Parkinson's disease, particularly in early disease stages. Therefore, there is also this issue of diagnosing, like early diagnosing. And also the tauopathies, they have frequently involvement in oculomotor changes. And this is where we normally, as clinicians, you have like a suspect of Parkinsonism happening. And we know also that through Prospect, there's been a huge focus on genetics and locus that transcribe for tau, especially a specific haplotype is a major risk factor for PSP. And Ed Jabari, one of his collaborators, showed actually that there is a genetic predisposition for long-term or short-term survival. All this is not that simple because even though we got neuropathological features, they are common, there is clinically heterogeneity and also variability where tau and the other cells when they are degenerated, can spread. And of course, there are these new concepts, new approaches in looking at the different cell types and what they are doing, not just tau. And the heterogeneity is one of the reasons why it's difficult to actually get an exact prevalence of PSP and CBD. There was this quite, let's say, big statement from this paper just recently published, that actually in autopsy is estimated there are 780 per 100K per people per year that get PSP, so 50-fold greater incident that we previously thought, but not all of them are clinically, let's say, evident. So Diane Swallow is a fellow that was partially funded by PSPA, and she looked at prevalence and studies that are focusing on detecting the real prevalence of PSP and CBS. And what she found is that, for example, in Scotland, where she's based, these are the crude point prevalence of the diseases. So there is a lot of variability on what we see in different studies. And again, she looked at the delay in diagnosis and the symptoms that normally are more frequent than in Parkinson's. The delay in PSP is an average of 3.3 years, in CBS 2.6. Interestingly, if you got the time to look at her paper, is that a bit of this delayed diagnosis is due to actually patients constrained, basically people that know there is an issue but actually don't think is yet the time to go and approach a clinician. And of course, then there is the problem of the delay access to services. So it's quite interesting observational paper. And as we know, falls and tremor are falls are more frequent and tremor is seldom present in PSP and CBD, and this helps differentiate from Parkinson's. So the big unmet needs is, of course, early and accurate diagnosis. Biomarkers has been a focus of many studies. For example, Prospect is looking into blood and CSF and the genetics variant. And there is also an idea now to look at quick testing of blood and CSF to have a straightaway answer if there is a genetic alteration or not. Imaging is, of course, another way of diagnosing the disease, and UCL, Oxford, and Cambridge are collaborating to look at using imaging to sequence the brain atrophy, to stratify people with the disease into stages and to track the disease progression. There is also, there was actually at the symposium reference to using peripheral tissues, like, for example, skin, to make the diagnosis. But of course, we are still at the point where we need a combination of all this to make a definitive diagnosis. So the clinical symptoms, the biomarkers, and the imaging. And again, this is the paper that is from the Prospect team and shows implication for clinical trials, because those are, of course, the one everybody's looking at to actually change something about the lifespan of PSP and CBD. And Professor James Rowe often refer to this concept that before you got symptoms, actually something started to go wrong even 40 years earlier. So we need to look at early diagnosis with the idea of we need to detect something in the prodromal phase. But before going there, even though there is a lot of work on it, we want to look at, I want to actually share a few tables that you can find in these slides, but also in the Professor Golby blog around PSP research that is really helpful to have updates. And he shared a few tables about trials that have been happening and they are going to happen. So we know that drug studies can be addressing symptoms, can be actually preventative or curative. And the curative area, there has been trials that actually failed to show any clinical improvement, even though there was the possibility of tau neutralization. But again, I'm not going to go through all of them, but just to show how many actually they are already happening. Sorry, I hope it's not too noisy. So one is actually current in Southampton with the estimated completion date in May 25, and sorry, May 24, and others again are using different molecules and different targets, and they are at different stages in the clinical trial trajectory. I just jumped to the last one to show that actually what is happening in the near future. And is quite exciting to know that Amylyx actually announced at the symposium there will be a phase 3 trial happening soon, even in UK. And PSPA, the public involvement group, has been involved in looking at patient faces information. We also engage with the because they acquired the rights to use another molecule, and they will potentially next year start a trial. And this there is actually a news from 2 days ago about the transposon therapeutics phase 2 trial that is looking at reducing the neurofilament in the spinal fluid, and they found a positive results. Now that again needs to be translated into clinical benefit, but at least we got something on the pipeline. And Professor Nigel Lee discussed the possibility of platform trial. He recently led an platform trial in ALS. These are trials where people are trying different drugs in the same time. This to reduce the timing of actually detecting some evidence of effect of different interventions, and also if there is the understanding that one of these drugs don't really work, there is all like the possibility for the patient to try another one in the same trial. So it will reduce much, like a lot, the time that normally takes to look at different drugs. I wanted to mention also non-drug studies, because there were some talks around, for example, the patient journey and the public. And I also added a digital health one. I think is quite interesting, using motor sensors. It was not openly discussed at the symposium, but I think it just shows how digital health is coming of hand, even because there are some subtle changes, for example, in motor skills, and Jade talked a lot about that actually machine learning and wearable technology can help with. And as I said before, there were talks about public perspective of having the condition, and there were specifically 2 papers discuss about interviewing people with the condition, carers and clinicians, to understand what are their needs, their real life needs. And this is because we know that we need their experiences to be key drivers of health and social care practice and research. And you heard from Dr. Ghosh, and he's in Southampton trying to actually influence the government to pay attention, basically, because we know that there is a right to drugs and treatment when they are recommended by NICE, and NICE is the provider of clinical guidelines, and for trusts to actually provide funding for specialist clinics, we need to create evidence. So there was a talk by Dr. Ghosh and also by Professor Golby about centers of care in US. And what Dr. Boyd discussed was the approach that in Southampton they're having with the multidisciplinary team, and how a new study that is going on is actually trying to create evidence in order to convince NICE that it is important to look at what's going on clinically in UK and make recommendation to trusts. And finally, wanted to mention at PSPA, we got an amazing group of carers and ex-carers. They're helping to shape research projects. And so far, we helped pharma, as I mentioned before, looking at patient-facing informations. Also, they help organizing agendas. They come to the research committee. They have their say. They basically are the voice of all the patient and carers we represent. And without them, also, we couldn't provide information to pharma how they could enable participants to enter clinical trials and other research studies, because we know it's not easy to live with a condition, but even more if the people needs to be, for example, transferred to get blood samples or imaging is even more a challenge. So something like this is really important to be fed back to whoever is designing a trial. And this is where we could help FAIR and Amylyx. And finally, just to show how much PSPA has been doing for funding research, and recently we put out call for small grants for allied health professional as well, to get career development opportunity, visiting sites that are active in research, and also fellowship plus projects of medium size. And we are in the process of actually finding the successful one. So that's it for me. And if you need more information, this is our email. And also, if you want to signpost people to be participants, we are now changing the form, but there is in our website a form where people can sign up to be a participant in research studies. And thank you for your attention.
Thank you, Annalise. A great job there. How you managed to combine what was an amazing 2 days in 20 minutes is outstanding. Okay, so that is the end of the program for today. So a couple of things I'd just like to do is, firstly, I guess remind everybody what we've covered just real quick. So I'm thanking them. So Dr. Boyd Ghosh, fundamentals of the conditions, the impact on quality of life, the value of coordinated care, amongst the many other things he shared, I thought was fantastic. Dr. Susan Connell, everything about cognition, and what I really loved was the comparison between the two conditions and the similarities, and linking the brain areas to the symptoms, and the special focus around language. I thought that was really, really interesting. And a quick shout out to our voice bank facility that you should look at on PSPA as well. Then just before lunch, we had Dominic, and all about the eyes. It was incredible. What a great presentation. Really opened up, sorry, pardon the pun, opened up my eyes as to what you can find out from looking at that, and what the opportunity is for things like that for potential future earlier diagnosis. Incredible. After lunch, a great presentation from Jade around the impact and value of movement, not only in terms of preventing the onset, but of well-being. I think that was really, really great. And just, you know, those simple things that make a big difference, sit to stand, really, really great. And I thought some of those videos and stuff were really super helpful. And lastly, again, thank you, Annalise, firstly, for doing a great job with the symposium in and of itself, and secondly, for summing it up. Last thing is help us to help you. I've just put something in the chat. If you would like to be involved with a conversation with Carol and the team from PSPA, please do email us. I've given you the format there to the email address. Follow up, collaboration, and tell us about you, your role, your specialty, where you are, and we'll get back to you sometime in the new year. All that's left to say now is thank you all for your time and attendance. And, you know, clearly you've all super busy, got lots of other things to attend to, but taking the space out to hopefully listen to the great speakers we've had has been a worthwhile investment for you. Obviously, yeah, we all know reason why we're doing this. Thank you for Carol and the PSPA team for putting this on. It's run absolutely smoothly, like clockwork. Thank you. That's it. Unless there's any other admin things, housekeeping, Carol, that you need to pull me up on.
No, I just want to say thank you, Paul, for chairing the day. It ran very, very smoothly. It was great. Thank you. Thank you for everyone for coming.
I was the tip of the iceberg. Everyone else behind the scenes was underneath the surface, making it all happen. So, yeah, no, thank you. Okay, I guess that's it. We'll bring that to bring that to a close, and we will we'll see you at the next instalment of our study day, or something else before.